Project Alivio. And Project Alivio, welcome. I see that you are with us. I will advance your slides for you, and we very much look forward to your presentation. So we are ready whenever you are. Thank you.
Hi, everyone. We are Project Alivio from the University of Michigan. I'm Sanj, and I'm here with Vidya and Mary. Next slide, please. Project Alivio works with a co-designed team of medical students in Guatemala from the San Carlos University. Our partner, SAMR, provides us with the necessary information from our target hospital in the city itself, but we plan to implement and test our product on our trip later this year. Next slide. To start off with our global health challenge, next slide. So why Guatemala? We chose Guatemala as our target population after performing a needs assessment across low-resource areas. Pressure ulcers, also known as bed sores, are injuries to the skin and underlying tissue that form due to prolonged pressure. Bedridden patients are the most susceptible, so hospital nurses need to turn them every few hours to alleviate the built-up pressure. Guatemala hospitals don't have enough staff to do this, and their current treatment methods such as pen and paper tracking or egg carton foam mattresses, as you see on the slide, are ineffective. Next slide. This brings us to a problem and need statements. So pressure ulcers are relevant problems everywhere, but current solutions on the US market, as seen in the top left corner, range from $1,000 to $15,000. So one of our needs is to make it more affordable and want to cater to a particular audience or market that needs the solution. They also don't have EHRs or electronic health records as we do in the US, for example, that keeps track of all the patients. So another need is to help nurses visualize the highest priority patients to turn. Overall, who benefits? Bedridden patients and working nurses by overall alleviating the physical demand of patient turning and ameliorating pressure ulcers. Next slide. Project Alivio is split into two sub-teams, the mechanical sub-team, which tackles the physical device, and the software sub-team, which manages the app connected to our device. Both sub-teams' prototypes aim to fully help the current nurse workflow from determining which patients need to be turned from the software side and actually turning them from the mechanical side. Next slide.
Now I'll be talking about the mechanical sub-team's design. Next slide, please. So we are building a system of airbags, valves, and a pump controlled by an Arduino to modulate the pressure on the patient's high-risk areas. So by inflating and deflating the bladders on different time intervals, we can redistribute the patient's weight over time, and that would prolong the time until pressure ulcers form. So these high-risk regions are seen in the diagram on the right-hand side, and the bladders targeting these areas are shown as the red rectangles on the top view of the mattress. Our measurements are based off of the head system, where each head or oval, as seen in the diagram, measures 8 inches. And these measurements are based on the Guatemalan population. Next slide, please. Overall, we chose our bladder, air pump, and valves to meet the requirements in Guatemala. Next slide, please. Here's our circuit diagram. The Arduino will control the valves, which times the inflation and deflation of the bladders. Next slide, please. And then this is a SolidWorks model of the container for our circuitry components. So there are parts where each component is placed and openings between them for the wires. Next slide, please. And then this is the current status of our prototype. So the yellow pouches are where the bladders are inserted, and each alternating set is connected to its own tubing and valve. We are using Velcro on one side of the yellow pouch so that the bladders are easily accessible and replaceable. This mattress will also be contained in a mattress cover to allow for easy cleaning. There will finally be a CPR release button and valve that will deflate the whole system in case of emergency where CPR is required. Next slide, please.
Cool. So now moving on to the software side of things. Next slide, please. Our software sub-team has developed an app that is complementary to the mechanical device that Mary just talked about in order to help nurses inform their decision-making even before they go to the device to actually turn the patient. Next slide, please. So our design for this app is motivated by 4 key principles. First of all, we want to have a minimalistic interface that really doesn't get in the way of the nurse workflow, but is still rich in visual information. We want to take into consideration the resource constraints, such as unstable internet in the hospital. We want to make sure that our app is secure above all, because we are storing some form of patient data. And last but not least, as always, we want it to be cheap and affordable to maintain. Next slide, please. So this is the general interface of our app. So as you can see, each patient is demarcated by a card uniquely identified by only their bed number. This circle right here is a clock telling you when the patient was last turned, or the time since they were last turned. As it fills up, it gets increasingly more red, and it fills up at a rate proportional to something called the Braden scale, which is basically a risk measure that nurses use to actually calculate and determine pressure ulcer risk. Next slide, please. If you expand the card out, you can see information really only relevant to pressure ulcer risk. So for example, weight, their Braden scale score out of 23, and even a mapping of where the ulcers are. Next slide, please. In order to make this user interface more manageable, you can sort on a bunch of criteria, as you can see in action here. Next slide, please. And you can filter in the same vein in order to really focus in on particular subgroups in case the nurse wants to see it. Next slide, please. In addition, we want nurses to be able to understand patient trends on a patient-by-patient basis. So this tells you how a nurse is, or a patient's rating scale has been trending over time, as you can see with this graph right here. Next slide. And then we want them to also get ICU level statistics. So for example, what is their median Braden scale value or stay duration time? Also, next slide, please. We can bucket patients by their Braden scale risk group, so moderate, medium, high risk, low risk, very low risk, and see what exactly the trends are in there. Next slide, please. Lastly, this is an architecture diagram of our application just to highlight some of the functionalities that we have to make the app function semi-functional offline, as well as some of the security measures we have in place using our cloud provider, Amazon Web Services. Next slide, please.
Moving into our future plans, next slide, please. Some of our successes have been completing the mechanical and prioritization prototypes, and these have been approved, and we've received great feedback from our community partners. Some of the limitations include, first of all, finding a testing environment analogous to Guatemala, since it is a lower resource community. And with this, measuring the effectiveness prior to travel will be a limitation because it's hard to find patients that will lay on this bed for long periods of time, and especially because our device will likely just prolong the time for pressure ulcers to form instead of just completely preventing them and the need for turning. Next slide, please.
So finally, as for the future, we first plan to locally test our innovation with nurses at Michigan Medicine. We want to compare how long it takes a pressure ulcer to form with our device and without, and perform customer surveys for subjective data to ensure comfortability and usefulness. For the software subteam, we plan to measure a mix of qualitative and quantitative data from usability testing. We also want to take these and then take it on our trip later this year in Guatemala to travel test. And then beyond this, we want to scale beyond the ICU in Guatemala and finally integrate the app with their device.
Have you slept on it?
Yeah, so we haven't slept on it, our individuals on the team, but we do have plans to set it up in like the Michigan Medicine Hospital. And so then when we do that, we'll have the patients sleep on it for at least a day, and so we can measure their comfortability there. But so far our team members have laid on it for like maybe 20 minutes or so long, and we've inflated it and deflated it, and there hasn't been any problems there in terms of comfortability. But we will definitely find out more when we get feedback from our hospital before we travel.
Having an app-based solution, would it, in the location you'd be using this, do they have availability of phones where they could have this app? Is that going to fit into the workflow of the actual nurses and other caregivers on the ground?
That's a great question. So currently the hospital that we're targeting isn't like completely devoid of technology. They do, like, nurses have their phones that they use. They do have some amount of technology there. Just the infrastructure isn't as robust as you would see in a place like America, for example. So yes, it would fit into their workflow. There are some things that they still do with pencil and paper that they believe themselves could be, say, automated by technology. So it wouldn't be like some sort of like complete surprise, if that makes sense, in terms of dropping an app in the work.
Next, we have Team Texas Engineering World Health from UT Austin. Welcome.
Hello, everyone. Thank you so much for having us here today. We are Texas Engineering World Health. My name is Monsi, this is Lizzie, and this is Manasa. And today we'll be presenting to you our project, a transport incubator made from recycled parts.
So to begin, our motivation for this project is, with our research, we found that about 1 million newborns die every year. And this is in part due to lack of access to incubators. Additionally, 75% of these preterm babies could be saved, and again, we found that this could be due to the limited access to neonatal care. So a little bit of background that we've conducted was that on average, incubators on the low end cost about $1,500 to $35,000. Additionally, some healthcare workers might lack the training to operate these advanced systems that might be sent to them. In general, there are also few reliable infant transport systems. Overall, low-income countries need better NICU care. So our proposed solutions comprised of using inexpensive and recyclable materials that can be sourced. Additionally, we wanted to ensure that we were using familiar hardware from everyday electronics, such as PCs and motor vehicles. Our product, we wanted it to effectively monitor temperature and regulate it, and additionally, we wanted it to be easily interactable with medical professionals.
So this is the general design of our incubator. As you can see, we have two systems in place. We have a cooling system and a heat generation system, and they're controlled with a circulatory system. So this is our CAD model. This is what we envisioned our incubator to look like, and this is what we were able to build using those recycled parts. Some of the recycled parts that we used were acrylic, foam, wood, and some electronic parts from PCs and car parts.
So in order for a neonatal incubator to function properly, we need to account for thermoregulation. So in our thermoregulation system, we have car headlights to generate the heat, and then we have a Peltier module that essentially cools for overheating. So essentially, Peltier cooling systems are found in common day fridges. So that's also another spare part that we've incorporated. Next slide, please. And so for our air control, we have PVC pipes. We've placed the headlight under the PVC pipe to generate that heat, and that essentially flows within our incubator model. And along with the PVC pipes, we have also incorporated the PC fans that Monica was mentioning earlier. So the PC fans allow for the convectional heat flow within our incubator. So we have them at 4 corners, and we also have heat sinks in order to also prevent the overheating aspect. Next slide, please. And our main electronic components are a computer power supply unit, computer fans, and the 2 headlights and the Peltier module. And in terms of our electronics, we were able to go to our university makerspace and find a PC and break it down into several different parts. And we found computer fans and also the computer power supply unit. And then on the right, we were able to incorporate that with the car headlight and generate our circuit. And for the computer power supply unit, we basically were able to divide it up into different voltages and power supply components. So for our Arduino, we used an Arduino system, which was powered with 5V and a temperature humidity sensor, PC fans, and headlights, and the Peltier module.
So this is our electronics setup. We had a on-off switch for the power supply, which powered the entire incubator. And we also had a temperature and humidity sensor, like Monsi said. And using that sensor, we're able to collect some preliminary data. So when exposed to external heating supply stimulus, you can see that the cooling system kicks in and it brings down the temperature back to a stable environmental temperature. In the future, we hope to use a saline bag to almost replicate or simulate a newborn child. As you can see from our bill of comparison, our model is considerably cheaper than a conventional incubator design.
So for future plans, we'd like to integrate a solar panel or a photovoltaic cell to maximize our energy with our power supply and make it more efficient. Additionally, we'd like to utilize the Hay and Katz nomograms algorithm, and this would allow us to personalize it to patients as it takes into the patient's weight, and this will allow us to maximize heating and energy efficiency.
Thank you so much for having us here today once again. We would like to extend our gratitude to the UT faculty, Dr. Tyron Porter, InventionWorks, International Biomedical, and the neonatal transport team at St. David's.
We'd also like to extend our thank yous to Dr. Rebecca Cordum. She's the inspiration behind our neonatal incubator.
In Mexico, in places such as Mexico and even India, a lot of incubators just go to waste because there's no maintenance team. They don't know how to operate those devices. So with our solution, we are incorporating familiar parts, such as the automotive parts and even the computer parts. And there are a lot of people who are familiar with those parts and who know how to handle those parts, as opposed to many of the parts just going to waste with like conventional incubators.
Hi guys, thank you for your presentation. My name is Sonia and I work at Rice360. My question is, have you guys thought of plans of whether to seek like say regulatory approval with this, or would it be like an open source, like I give you all the materials? And then I have a follow-up question.
Okay, that's a great question. So we were thinking of creating a manual and using, like we said, different spare parts and other parts that we can replace. So with the power supply, one idea that we were entertaining was using a SLA battery, a car battery. So we found that it wasn't as safe as a PC battery power supply, but in the future, we'd like to create a manual so that those parts can be replaceable.
Parts that we did use were pretty standard. They're pretty standard. So in order to incorporate into the manual, there should be ease of implementation.
Yes. Yeah, my other question was like if the acrylic was actually recycled, because it's not readily available in low resource settings. Thank you.
Again, similar to the power supply question, with the manual, we were hoping to source materials that might be commonly found. In addition to that, that would include the acrylic.
Had any thought or testing into different ambient temperatures and humidity, if that affects the setup at all?
It shouldn't. So in future testing, we plan to incorporate like a load cell that accounts for the patient's weight. So Lizzie mentioned the Hey Cats monograms. So that's essentially like a pre-built algorithm that accounts for the weight of the child as well as the age for the child. And depending on that, there's like a thermo-neutral temperature range for the patient. And we'll also account that for in our software section. Yeah.
I'd also like to add that we do have an overhead cabin, which is where the patient will sit, and then we have a basement, which is where all the electronics sit, and we've made it where even if there is a certain humidity, it shouldn't affect the actual circuitry of the device because it's sitting away from the internal temperature, the internal environment that we're creating.
Up next, we have Team Baby Belt from Bangladesh University of Engineering and Technology. Welcome.
Hello everyone, I'm Anika and this is my teammate Juicy, and we're from a small South Asian country called Bangladesh, and we're here today to talk about pregnancy and labor. Any pregnant women of any global or social background, it is a primary need that they can access proper healthcare during the last trimester of pregnancy. However, that is not always the case. As we see here from the WHO data from 2020, globally about 800 pregnant mothers die every year during childbirth. 95% of who come from low or middle low income families. Also, threats like preterm labor, uterine rupture, fetal distress can pose fatal risk for both the mother and the baby. To solve this, we need to properly monitor the last months to detect of any kind of abnormalities. Currently, the CTG or cardiotocography machine is used for this purpose, from where the doctors can monitor both the uterine contractions and fetal heart rate, as both of these are supposed to be in a distinct pattern during labor. However, the CTG machine is very bulky and tech dependent. For the rural people of Bangladesh or other countries like Africa or South America, it's tough on them to visit hospitals regularly during the last trimester and get proper monitoring. And so, such fatal accidents is a major threat to them. Hence, we propose Baby Belt, our original device for the monitoring of gravid mothers at home. So our main target for this device was to make it as accessible as possible for the low-income population by cost reduction and user-friendliness. Also, we offer the idea of an algorithm for detecting abnormalities beforehand. So when we say the device is low cost, we can easily see that the CTG machine costs about $2,400 USD. A portable machine called Baby Bell that is Bloom Life that is found in the market costs about $164 USD, whereas our Baby Bell costs only about $40 USD. Also, it comes with a subscription-based model.
So now let's look at our design rationale. Our device is mainly a wearable belt where we integrated completely fabric-made pressure sensors. The fabric-made pressure sensors make the belt lightweight and adjustable to different physics. We incorporated the sensors on the key location point of uterine contraction propagation. Now let's look at our key technologies and the platforms. So what makes our device special? Our novelty is mainly the non-invasive pressure sensors, in which we use a material called Velostat. Velostat is basically a low-cost packaging material, but it has a very convenient piezoresistive property, for which if we apply a pressure, its resistance changes. One sheet of Velostat costs $4, from which we can make at least 100 pressure sensors, which reduces our cost significantly. Now this is a schematic of our sensors, and this is the real sensor that we made.
Now, to monitor the fetal heart rate, we can see that it is only a stethoscope head with a condensed microphone with an amplifier attached to it. It detects sounds across barriers and is a very easy solution to detect fetal heart rate by detecting its heart sounds. The data Baby Bell gathers can be transmitted using cables or also can be made wireless in the future. The data we gather can be used by doctors to make assessments about a patient. Also, with enough data, a huge data set can be built for developing detection algorithms. To develop algorithms, easy languages like Python or MATLAB can be used. Also in future, machine learning or AI can be used for more accuracy.
So our device has pressure sensors and a fetal heart rate detector, but are their readings similar to the standard clinical devices in use? For validation, clinical trial has a long approval process. So what we did is we made a setup that mimics the maternal abdominal distension during uterine contractions. The setup includes an inflating soccer ball, where we generated the pressure in the same range of the maternal abdomen, which is 0 to 99 millimeter mercury. Then on the same setup, we used the CTG machine and our sensor and obtained the results. From the resulting plot, we can see that our sensor reading and the CTG reading matches significantly. Further, if we use a correlation analysis, we can get a significant R-square value of 0.9. Another novelty of our device is the spatial distribution of uterine contraction mapping, which is currently not available in the CTG machine. We use 6 sensors and another mimicking setup to illustrate the spatial acquisition.
Another novel part of our device design is the circuit we made. It's just a simple Wheatstone bridge configuration with a potentiometer that helps to get rid of the fluctuating baseline and noise we see in the left picture and makes a more smooth pressure curve like in the right picture. Now let's look at the fetal heart rate monitoring system. Here we can see it being tested on a real-life patient, and we can see the sound waves being detected. However, we could not use filtering and data processing on that data that we gathered. So rather, we used a phantom abdomen mimicking the mother's adipose tissue and on an adult. So we used it to cover the heart of an adult and used our device to detect the heart pulse, and we can see it can easily detect the peaks. From this, we can find the heart rate of the patient, and simultaneously, we used ECG to find the heart rate. And in those heart rates, we found 98% accuracy, and so that concludes that our device is workable.
Successes of our device include acquiring uterine contraction and fetal heart rate data for clinical detection. But there are some limitations that non-invasive devices usually have, like relative pressure readings instead of actual pressure readings, movement noises, and different physical structures. Our future plan is quite extensive. Firstly, we want to make the device wireless for wear of comfort. We also have plans of developing a detection algorithm and a filter processing technique for differentiating the fetal heart rate from maternal heart rate and breathing noises. For this, we want to take parallel ECG and EEG data with our device, and with significant data set, we incorporate machine learning algorithm to achieve our goals.
Our team consists of 3 members. One of them could not be here due to some personal problems. All of us are from the Bangladesh University of Engineering and Technology. We major in the biomedical engineering, and all of us are third-year undergraduate students. And these are our supervisors and project advisors who have helped us along the way.
Are you attempting to automatically detect the risk condition or merely make the data available to be monitored by a medical professional?
Yes, we are actually targeting to gather the data and then gather all, let's say we have a population, right, in a city. So we gather the data of all the pregnant mothers at a time. So all the data will be uploaded in a server. So let's say there's a doctor at New York, and the patient is, let's say, in Houston. So if the doctor cannot actually access the patient, he can still monitor the data from the server, and the patient can wear the belt at home. That way, all the visits to hospitals, they can be eliminated or at least reduced, because in the rural population, the patients don't actually have that luxury to all regularly visit the hospitals. It's very costly and expensive for them.
Okay, thank you, I understand. Is it the case that the conditions that can be detected in this way can be treated in a timely enough manner that even if they were remotely detected, for women in a very rural situation, they would be able to take effective action or get to a doctor?
Yes, our main objective was early detection of anomalies like preterm labor or uterine rupture. So if we have like a device that can be used at home, the early detection can be possible with our data set, and thus they can easily access to the hospital when they need it.
So what we're proposing is that, let's say the doctor is seeing from the device that the patient is going into labor. The patient won't know that. Maybe she has a preterm labor, right? So the doctor will then notify the patient that it's time we go to the hospital. So she can just go to the nearby hospital and just be ready for delivery. or most of the patients in the rural section of our country, they just opt out to go into hospitals and they just get the delivery done at home, which is more risky and had sanitary issues. So.
Did you evaluate compliance if somebody is going to be wearing this at home? Do they know how to put it on appropriately, make sure it's functioning, and would they bother wearing it all day long? Does it become annoying and uncomfortable and people would just end up taking it off?
In our country, we actually have some family planning volunteers who go to the rural areas and they teach the pregnant women about family planning and other maternal security issues. So we plan to use our device with those volunteers so they can educate them, they can teach them how to use it. And for the word of comfort, as our device is completely fabric made, we have validated the device is comfortable, but we plan to expand it further. There are some sensors that are still very bulky, so we need to minimize them, and we need to minimize the circuits, and we need to make it wireless, so the wire of comfort increases.
How did you come up with the number of sensors for the pressure sensors?
If we show the physiological propagation of uterine contractions, here we can see the physiological propagation of uterine contraction. The contractions actually begin at the two corners, and then it propagates, and then it maximizes in the fundus, and then propagates downwards. Okay. So the action potential starts from any of the two corners, and then it matches in the fundus where it maximizes, and then it propagates downwards and gradually decreases. So we use the 6 points that are optimum, but not much and not less either. So that in that way you can get a spatial mapping of the uterine contraction. So the action potential starting, then the maximizing the fundus, and then gradually going downwards.
Welcome, Team DIT. Welcome. It's so good to have you with us, joining from Dar es Salaam.
Hello, my name is Michael. I'm member of Team DIT. I'm here to present about the project, which is access your health records anywhere. This is all about when you have to travel from one place to another. You don't have to be stressful for maybe forgetting those documents about your health documents, and this will make you comfortable. Next, please. In our presentation, we have these contents. First is our teams, then introduction, solution about these problems, and conclusion. Next, please. In our team, we have 5 members, which is Michael, Douglas Widam, George Prosper Mushi, Eric Leonard Shayo, and Eric Frederick Msigwa. And these are members of this team. Next, please. As I said before, we are here to solve about the problem for those patients who have long-term medical problems. The system aims to solve the issue of patients having to carry physical copies of their medical records and drug information while traveling by providing them with digital access to this information globally. This is because you don't have to be stressful when you want to travel from one country to another because you forgot those documents. So the aim of this solution is by providing the system which the patient can access their information globally without stress. Next, please. These problems are several outcomes. And one of the outcomes, next please, is stress to the patient. When a patient forgot those documents from the foreign country, he or she must be stressful because he can't get his medical records, and sometimes the medication from those institutes or hospitals or whatever, it becomes somehow difficult. So due to this, the patient becomes stressful due to lack of previous information of his medical records. And the second outcome of this problem is multiple diagnosis, which is because sometimes those health institutions like hospitals and whatever, they must have to perform multiple diagnosis. And some of the diagnoses take long time. This make not well situation in our society. Problems is with diagnosis are not required to perform multiple. For example, X-rays. When you perform X-rays and the other which include these rays, it is not good for the human being. So this patient must provide money in order to his. Next, please. System in which all medical information for a patient with long-term medication is stored and be found in any country. Next. And now I'm gonna show you how this system will work. Next, please. The first is registration of health centers. And this patients are registered in our system in order to be stored as medical records. And for this, will help his medical records be accessed globally. Next, please. Next, please. The second is registration of the patients, which done by health centers. Those health centers which are registered before, they have to having their.
My question is if these health records are meant for the patient to have access to, and maybe they can take it to different doctors, or will it be for the doctors to have access to these patient records? Thank you.
Okay. This system to make this information about your health records to be accessed globally, not by you as a patient, because when a patient you give him access to view the health information, it may be unsecurable because sometimes cyber security is one of the problems in our society, as we know.
The legal issues between transporting medical information between countries, sometimes the laws are different.
Okay. Because in the world we have common institute, which is governed by UN, and this is able to provide and assign rules which will govern our system and can be accessed globally by any without regarding those rules about your countries.
We have Team Smart C from the University of Pennsylvania. Welcome.
Hi everyone, I'm Neha and this is Shreya and we are Smart C. We have developed a wearable band and mobile application system to detect post-C-section surgical site infections. Each year, there are over 29 million patients who deliver by C-section every year. And up to 4 million of these patients end up developing surgical site infections, making this the third leading cause of maternal mortality worldwide. Surgical site infections also have elevated risk factors in global health settings because patients have limited medical knowledge, there's unsanitary conditions, and also limited access to health care. Under the current standard of care, patients have to self-monitor their wound site every single day for up to a month, and this can obviously pose many challenges for a new mother who's dealing with a hectic postpartum period. It's also hard for her to visualize a wound site because many times new mothers have a pannus, which is a flap of skin or fat that hangs over the C-section site. And when they can visualize it, it's hard for them to tell if something is actually wrong because infected wounds and healthy wounds can look very similar during the early stages. And on top of that, patients are missing their follow-up visits with their doctors. So there's a very clear need for an early automated at-home infection detection tool. Introducing SmartC, a wearable band and smartphone application system that enables the detection of post-C-section surgical site infections. In order to detect these infections, we're looking at 2 different biomarkers, with the first one being temperature. We're looking to see an increase of 1.5 to 2 degrees Celsius or a fever, and we're using medical grade temperature sensors with a granularity of 0.1 degrees Celsius. Our second biomarker that we're looking at is pH, and we know from literature that wounds tend to become more basic over time as they get infected. So we want to use a sensor that has a sensitivity range between pH of 4 to 9. And we'll be continuously monitoring these biomarkers every 30 minutes. Because there is no pH sensor on the market made for our needs, we decided to fabricate our very own novel textile-based antimicrobial low-cost pH sensor using a conductive polymer called PANI. And the way that PANI works is that it essentially changes its resistance in response to different pH levels. We are housing all our sensors within a daily changeable wound dressing to maintain hygiene and also to minimize risk of infections. And here you actually see the changeable wound dressing. The first few layers are moisture wicking, so any blood, pus, wound, any exudate is taken straight to our pH sensing layer, which is basically a cotton that's coated with our polymer. And then we have a couple liquid absorbing layers. Then we have our temperature sensor, and then also the back of our dressing has a conductive Velcro, so it can be easily removed. And then finally, our entire circuit is connected via conductive thread. Our sensors will be collecting data and sending it over to our Arduino, which will wirelessly send this to our broker via Wi-Fi, and all our visuals will be seen on our smartphone application.
So SmartC has a competitive advantage. There are smart bandages, but they're not intended for anything other than chronic wound monitoring, and they're also not tailored for at-home needs or postpartum needs. SmartC, on the other hand, is tailored specifically to detect surgical site infections, and it also addresses postpartum needs in a unique way for global health settings. So we do this by using a material that's both compressive and size inclusive to maximize our comfort. We also use an LED indicator, so in areas where Wi-Fi is not reliable, patients can still be notified that they are at risk for infection, even if they can't access the mobile application. We also have a lot of elements that promote reusability of our band because we have a rechargeable battery that has more than 12 hours of battery life, which is the amount of time the patient needs to even wear the band every day. And we also enable our band to be washable and cleanable. We do this by housing all of our electronics in a detachable pouch. So our printed circuit board is located within the pouch, and the pouch is connected to all of the rest of the electronic circuit via conductive snap buttons. And we also have a zippered charging port that allows the electronics to be easily accessible and protects them from the day-to-day use and wear of our device. So our product has actually evolved a lot since we first designed it. And after multiple design iterations, today we come here with a full working prototype. We also have already validated our pH sensors because they were pretty novel and new, and we did this in a controlled study. So we actually soaked our dressing in a pH 4 solution, which is the baseline pH of skin in a healthy wound site. Then we incrementally added a high pH solution, and we saw a response of increasing resistance as expected in our pH sensor. And this was very similar to the data we've seen in literature as well, and kind of gave us more confidence that we'd be able to detect infection using this biomarker. The future of our R&D and clinical studies includes launching a pH and infection correlative study to really hone in on the threshold for infection detection. And then we also plan on getting a better idea of what our accuracy looks like for our device. So we want to get a better idea of our false positive, false negative rates, and be able to mitigate some of these risks. So our business model is built specifically for being sold in global health settings or being used in global health settings, and SmartC will be sold directly to hospitals. So in higher resource settings and these markets, we'll be able to have every patient use a band and dressings. But in lower resource settings, we'll be able to leverage the revenue from our higher resource markets and implement a many-to-one model. So a bunch of patients can actually share and circulate one band because it's washable and cleanable, and each patient will get their own supply of dressings. So this greatly lowers our cost per patient for the hospitals and also enables us to reuse this band within the community multiple times. In addition, we estimate the hospitals in our markets will be able to save $8 to $20 million just by utilizing our device and decreasing a lot of the readmission rates and complications that come with this. So at SmartC, we're a team of bioengineers that are passionate about reducing the maternal mortality crisis, working with a great team of clinical and material science experts.
When a wound infection develops, it usually starts deep down in the wound and then eventually will become apparent on the skin. At what point would the pH start to increase on the skin if a wound is developing in the subcutaneous tissues deep down below that?
So we actually have some studies that help show this trend. So you can see like across day 10, day 12, it kind of differs patient to patient, but you see that upward pH trend in chronic wounds, and we expect this to happen earlier in surgical site infections.
So it's actually, thank you for your response and your time and your dedication to this project. My question to you for the low income setting, you propose multiple people in sharing a band. How do you propose to do that?
Yeah, so I think going back to what our device is structured as, we have daily changeable wound dressings that are attached on top of the band, and the band itself is just basically a cloth, a fabric, and so not every single patient in a community is going to be having a C-section at the same time. So you can have like 5, 10 bands for a small community and be able to wash them between each patient and just get separate supplies of the dressing for each patient. So we're able to reduce our costs greatly through that model.
We have Team Pulse Oximates from Georgia Institute of Technology.
Hello, everyone. We're Pulse Oximates from Georgia Tech. My name's Allie. This is Herschel and Marshall. So if you've ever stepped foot in a doctor's office or a clinic or an emergency room, you've seen a pulse oximeter before. And this little clip that they put on everyone's finger is known as the pulse oximeter. It has the important job of measuring a person's oxygen saturation percentage, which tells clinicians how well your respiratory system is working, how much of your blood is carrying oxygen versus not. So this number is very important for making care decisions, and this is one of the only diagnostic tools during COVID that help determine whether or not patients could get a bed in an overwhelmed hospital. However, we've been proven time and time again that in people of color with darker skin tones, it doesn't work. So the melanin in their skin interferes with the lights that are used to measure the oxygen saturation. And it will actually inflate that reading and give them a healthy saturation value when in reality they have dangerously low saturations and need treatment. So more than 1 in 7 people of color experience these inflated readings, and that's 3 times as much as in any other patient. And that gives them a 70% higher chance of in-hospital death. But that doesn't even account for those that were deemed falsely ineligible for treatment during COVID and they were sent home, where obviously they deteriorated and eventually they could die. So the number of lives that have been taken by pulse ox is a lot higher than what we've seen with these in-hospital deaths. So this engineering failure is severely disparaging a population that is already disparaged in all walks of healthcare and are already at higher risk during pandemics such as COVID.
So our solution, we have redesigned the pulse oximeter to create a sublingual design. The way that the design works is that it goes into the mouth, under the tongue, and an accurate value is given within 10 seconds. Looking at the advantages, with the finger design, there are a lot of inaccuracies, the biggest one being skin tone, race, ethnicity. Other values, inaccuracies include cold hands, nail polish, and poor circulation. With the sublingual design, those factors are immediately eliminated as there's no skin tone in your mouth. The mouth is very warm. There are no external factors, and there is also a good circulation as the tongue is very vascular. So for our prototype is in a box-shaped design and has an OLED display, and this display displays the accurate values. It also has a power switch that turns the device on and on. Protruding from the device top is the 2-prong design. This is the sublingual silicone mouthpiece. That mouthpiece has the IR and red lights. It also has a photosensor on the other side of the prong. The silicone itself is a medical grade material. It is very comfortable to the mouth and very, very easy to digest in your mouth, I guess. The device goes under the tongue. So with the silicone being very flexible and very able to move around, it is very comfortable and can fit any size, shape, and mouth size.
Although our device is novel, simple, and very efficient, there are a couple of challenges that we have faced. The first of which is the fact that we want to make our pulse oximeter reusable. Having a reusable device allows for physicians and healthcare workers to be able to keep track of it a lot more efficiently. Additionally, it saves a lot of money, which is very important, especially in third world countries. To combat this issue, we decided to come up with plastic sleeves that are single use. These plastic sleeves help slide under the prongs and can be used on each and every single patient. Testing has already been done on these sleeves to ensure that there is no leakage and no contamination when using from patient to patient. Another issue that we faced is the potential risk of wire exposure. Patient safety is very important in medical devices, so to combat this issue, we decided to use silicon of a hardness of 30A. This structure allows for the wires to be held properly in place, but is also malleable enough to ensure that none of the patients face any discomfort when putting the device in their mouth. The largest challenge that we have faced is calibrating the device. Currently, pulse oximeters are calibrated by testing each pulse oximeter to each other. So if one of them has an inaccuracy, all of them will also have that same inaccuracy. To bypass this issue, we have decided to create our own benchtop model. We're currently in the process of doing that, but to bypass that issue, we've already done testing on cadavers as well as preliminary testing on ourselves. This has shown us that the technology that we're using does currently work. Here is a quick diagram of the technology. In our circuit, we're using an Arduino Pro Mini along with 2 different light sensors, a red light sensor and an IR light sensor. From this, a photodiode gets the values that are sent across the tongue under the sublingual region, and using an algorithm that we're currently calibrating, the proper oxygen saturation value will be displayed in the OLED display. Currently, we've already done cadaver testing, and we're in the process of optimizing the design along with calibrating the device. In the future, our goal is to get to FDA clearance and to the markets. Our goal is to aim for hospital uses, and since our device costs less than $10 to make, it won't be hard to get into hospitals. Additionally, we want to make sure that this device can be used all around the world. So as soon as we go to hospitals, our goal next is to make sure that we can market to people specifically. Thank you.
So I had a question. One, what is the oxygen saturation in cadavers?
Yeah, so that's actually a really good question. The reason we did cadaver testing was to ensure that the technology itself goes like through the tissue. In cadavers, with the formaldehyde that's added to the cadaver, the area under the sublingual region is a lot thicker. But the main reason we did that was to make sure that the underlying lights in the pulse ox go through the area. We weren't able to get an accurate oxygen value because our device isn't fully calibrated yet, but that's what we want to do in the future.
Yeah, very interesting presentation and an obvious problem to be attacked. I'm a little fuzzy on how you've validated that the readings that you are getting are accurate and what you're using as your control.
Right, so as of right now, we're not actually like measuring saturation itself. We're just making sure that viably the light passes through at a measurable amount that we can differentiate between the two different lights, because it's the ratio between infrared and red that kind of passes through the tissue is how you calculate an oxygen saturation percentage. And so what we're kind of doing right now is just making sure that we can pass enough light to calculate that value, because the calibration kind of comes after that. So we know the technology works because we are passing enough light that we could calculate the percentage, but calculating an accurate percentage requires extensive testing. So the way they do that now is they'll take their new pulse ox that they designed, and they'll take a working pulse ox, and they'll kind of put them both on, and they'll build their own curve of expected like light values that they get for each saturation percentage. And so they're kind of referencing a device that also doesn't work. And so they're getting the same biases and inaccuracies in their new device that they had in the previous device. And so we didn't want to calibrate that way. So we're building our own benchtop model to kind of circumvent the melanin and the inaccurate device altogether.
So what will you use to validate that your device is giving you accurate levels?
So
that's still my question.
Yeah.
I understand the concept that you're bypassing the issues with skin tones. So just if you could just, because calibrating it to itself isn't going to tell you if it's accurate. It's just going to tell you that you've measured something.
Yeah, so we're using a benchtop phantom model. So there are ways to optically replicate fully saturated blood and unsaturated blood. And so we're using that to kind of calculate our device without the interventions of like using a different pulse ox or using like human models. And so that kind of also circumvents getting an IRB approval. But that's down the line for us, is validating this in like clinical trials.
Yeah, I guess adding on to Ali's question, currently the only gold standard level is an arterial blood draw test, but the reason that isn't really used is because it's really painful, it takes a lot of time, and it is pretty expensive to continuously do over and over. Once we do finish benchtop modeling, we do want to run a couple arterial blood draw tests on ourselves to ensure that the values are accurate.
I have a question on when you consider putting that in the mouse, have you considered approaching from the ear or from the nose?
Yeah, that's actually a really good question. Currently, there are devices that do look at other areas of the body. The finger is the most common, but some places look at the earlobe, the septum, the toes. The reason why we decided to go sublingually is because most of the other regions that are currently looked at still have the issues and the factors that are still inducing that bias, especially in that racial diversity aspect. Testing sublingually gets rid of a lot of the factors that Herschel was mentioning earlier, especially the skin tone factor.
Yeah, we actually talked to an ENT as well about this, just to make sure that measuring sublingually was viable in the beginning of our like conceptual design. And because the tongue is so vascular, we'll get more accurate measurements to what's actually happening in your respiratory system, because it's got a lot of that freshly oxygenated blood, where if you go in the ear or in the septum or on your finger, it's a lot of capillary blood, which has already started exchanging that oxygen with the tissues. So you're losing out on what is actually happening in that exchange.
So just a couple of quick questions. Thank you for your presentation. So have you considered what it would be for children, or who's your target population? And then any challenges that you anticipate with the reuse aspect of the device?
Yeah, so currently we decided to focus on adults. This project was actually in coordination with Neonatal Rescue, who does a lot of projects globally on neonatals. But after doing a lot of research and with the talk that the FDA had actually a couple months ago, we decided to focus on adults first, just because the underlying process of gathering the oxygen saturation from babies versus adults is completely different, just because of like body structure, size, and everything. So while we're currently using the device on adults, in the future we do want to look at the neonatal market and looking at children. The underlying technology between current devices that are used for neonatals and children isn't too different. So the technology that we are using should be fairly similar. It's more about making sure that we can create a device that fits their mouths instead of adult mouths. Could you also repeat the second question? Oh, yeah, the reuse aspect. That's actually one of the most important things. A lot of pulse oxes currently in hospitals are like one-time use only, and it does induce a lot of waste. But making sure that the device is reusable helps solve a lot of issues. Contamination is one of the biggest things. So having the plastic sleeves around the prongs that enter the mouth ensure that there is no cross-contamination between the patients. We've already done testing to ensure that there is no leakage inside of it. So any saliva that's on the outside, or any water, like residual water from the mouth that's on the outside of the device, will not be able to enter the device directly. So once you're able to remove that plastic covering and put another one on, you should be able to enter it into another patient's mouth.
Thank you for your presentation. Does the temperature inside the mouth, have you guys thought about challenges with the calibration? Because depending on what the person has eaten or had to drink, does that change it?
Yeah, that's actually a very good question. It's something that we have to see as we calibrate the device. Obviously, the mouth is a lot more like thermally regulated compared to other areas of the body. I guess one story I kind of like to tell is I was actually working at a nursing home, and a patient actually had a 66% oxygen saturation, according to the reader. But once the nurse took her hands and kind of circulated it a little bit, rubbed it, that value shot up to 97%. The mouth itself is a lot more thermally regulated, and although it is hotter and there are some other factors like food that could potentially influence it, having that plastic covering on the outside of it should be able to like regulate the values a little more. But obviously a lot more of that will be seen as we continue testing.
We are honored to have with us Team Travania from the Malawi University of Business and Applied Sciences.
Okay, so we're Team Travania from Malawi. We're a group of 4. We're all from the Malawi University of Business and Applied Sciences. My name is Darito Bachola, and I hope you can hear my other teammate. His name is...
My name is Innocent Samuel. And my name is Mades Fatson.
Okay, so our project was a laparoscopic training kit. So I hope Malawi, okay, so laparoscopic training kits, I don't know if you guys have ever heard about it, but it's a kind of surgery that is done using a screen and a digital camera. So what happens is there are these endoscopic staplers that have a camera inside, and the camera is put inside the person's body to perform the surgery. So this surgery is designed to be non-invasive so that a patient does not have to go through a lot of days of healing. So in Malawi, it is a very low resource setting country. So this laparoscopic surgery is very hard to practice in our country. So because of this, we saw the need to design a training kit so that our Malawian surgical students at the University of Kamuzu University of Health and Sciences can practice using this training kit. So the reason we designed one was because the laparoscopic surgery training kits on the market are very, very expensive. And also, there are also few training kits in Malawi as opposed to how many students there are at the university. And because of this, because of this, we say students should be able to practice this surgery, because it's not right that they cannot be able to practice this surgery because of no funds. So our design criteria, thank you. So when designing this training kit, we wanted it to have an efficiency of 70%, meaning that the efficiency of this training, of this laparoscopic surgery training, should be very efficient to these students, so much so that they really know what's happening. In this sense, we mean they should learn how the laparoscopic surgery should be, how precise they should be when performing this surgery. Also, we wanted it to have a light intensity of 1,400,000 lux, meaning since our training kits, they're supposed to see what's happening. So the light intensity should not affect their vision. Also, we wanted it to have a power source of alternating current of 220 volts to 240 volts, because this is the electricity requirement that is given in our country. And also a DC current of 5 volts to 12 volts. We wanted it to be a low cost. As we said, that was the main reason why we designed it. We wanted it to be low cost. So we wanted it to be less than $100 US. Easy to use. In this sense, we meant that our users of this project should not have a hard time to operate this device. We wanted it to be easy to carry in terms of portability, so that they can carry it wherever they're going. If they want to practice, we don't want it to be a big device, so that they can practice in whatever rooms they're in, because our college spaces are very tiny. So we wanted the device to be operatable in every other place they're in. And we wanted it to have high tensile strength, meaning that it should be very strong, so that if any kind of damage comes to it, it should not get, if any kind of impact comes to it, it should not be damaged. So on the next slide is a picture of our prototype. So my colleague is going to explain how it works.
Hi, my name is Innocent Samuel, and I'll take you through our prototype, which is the solution that we designed. And in the picture that you can see is the laparoscopic training kit that we designed. Basically, we used an artificial intelligence, whereby we used the Raspberry Pi in a way of displaying what is happening inside. As you can see the box, we have a suturing kit that is inside the box. And the 3 holes that you can see there, they're designed for the endoscopic staplers to be there and to be doing the suturing or even any surgery that will be happening inside. Yeah. So the display actually analyzes the accuracy of the suturing, or the percentage of the suturing that will be happening inside. Yeah. So as you can see in the picture, it's portable, and also you can see the light intensity that we used inside, so that the display can actually see everything, or even the surgeon or the medical student that is analyzing or training through the laparoscopic training kit will be looking or seeing what is happening inside accurately. Yeah, so that's all about that prototype that you can see there.
So on this slide, that is the description that my partner here just described. So on the next slide, this is just our prototype success and our limitations, the limitations that we faced. So in terms of success, our prototype was able to depict the laparoscopic surgery procedure. So when one is practicing using the endoscopic staplers and the surgery bays, one would be able to see how this person is performing their laparoscopic surgery. So we believed that this will teach them precision because, as we all know, practice makes perfect. What our prototype did not achieve at the moment, but is what we were trying to improve, is trying to make it. We're trying to incorporate a system that will be able to give feedback to our user or the medical student that whether the procedure they're doing is how accurate or how precise, or what other skills they need to practice more in order to succeed in this surgery. So the planned improvements are using artificial intelligence to direct our user on how to improve their procedures. So on the next slide, that is really much about our prototype. So on the next slide, these are just a few references, not all of them, but just a few references that we use to come up with our problem statement. But most of our information came from interviews with these medical students and interviews with lecturers from the university. And would also like to thank Mr. Hilary Lodzanyama, who is the Design Studio Manager of the Malawi University of Business and Applied Sciences, and also would also like to thank Ms. Wu Moyo, who was the previous Design Studio Manager of the Malawi University of Science and Technology. These two helped us in designing this prototype and bringing it to as it is now. Thank you very much.
What is the penetration of lab surgery versus open surgery in your country?
Pardon? Sorry, can you please repeat the network?
What is the penetration rate? Like, what is the ratio of total operations that is being done laparoscopically versus in open surgery fashion?
How people are practicing the laparoscopic surgery in our country?
Yes, exactly.
Oh, okay. So as of now, it's a new development because our country is, like we said, it's still developing. So this surgery just came in, but it hasn't really been implemented fully because of the technology limitations, but it's a requirement. It's a requirement to most people, but it just hasn't been implemented fully. So as of now, we don't have the full statistics of how it's being implemented because that information is very difficult to find.
So I can also add on that. We tried to consult some nurses at Queen Elizabeth Central Hospital in Malawi, Blantyre, whereby they said, as the statistics shows, it shows that there is a need of laparoscopic surgeries to be done, but because of the access to the surgeon or the medical students to the laparoscopic surgery, they don't do it. So they end up doing open surgery that is more invasive than doing it using the laparoscopic kit. So that's why we came and we designed this laparoscopic training kit.
Hi, could you speak about the material that you're using to mimic the operating wound and whether that is a one-time use or is it reusable, and if that material is readily available?
So the material we used was a surgery base. So it's not a one-time use kind of material. It's a material that can be used over and over again, but for a specific period of time until it wears out. So yes, it is readily available. It's readily available on the market because the one we purchased it on Amazon just for prototyping testing, but because we were not able to produce a material that could be able to mimic the skin properly. So the surgery base was the one that we had available at the moment, but any other materials in medical schools can be used to mimic the procedures.
Celestial Trio from Bangladesh University of Engineering and Technology.
Hello everyone. This is Team Celestial Trio from Bangladesh University of Engineering Technology, Bangladesh. I, Shaukat Osman Shishir, along with Tanmay Chandra Shaha and our friend Maqsadullah Krafi, we have developed a low-cost portable automatic external defibrillator. We all know the severity of the sudden cardiac arrest worldwide. It causes 15 to 20% death globally worldwide, and which causes 39 a death per 39 seconds. The only solution to resolve this problem is an AED. An AED is the only device that can enhance the chances of survival. But the main problem is it costs around $1,300 to $3,000, which makes it unaffordable for the low resources hospitals in developing and underdeveloped nations that is located in the rural area. And furthermore, it has another problem, that is it can't provide user-specified shock. That means a person of 200 pounds does not require the same energy to stop the lethal arrhythmia that a person of 100 pounds. That's why we need a low-cost AED to solve this problem and a more sophisticated weight-based algorithm to detect lethal arrhythmia like ventricular tachycardia or ventricular fibrillation. And since the lower income country has a power problem, that's why we need to make it with the supply to connect with the supply line and a DC line, and we need to produce the necessary biphasic shock. So we have designed an AED, and we have innovated and such an algorithm, weight-based algorithm, which can detect lethal arrhythmia and will provide the necessary shock if the arrhythmia is detected with its respect to the weight. Here you can see the diagram where the ECG is collected, and then you have to put the weight of the patient. Then our algorithm will analyze it, and if the arrhythmia is detected, the necessary shock will be provided according to his weight. And the main cost behind our low-cost AED, our AED will cost, if we'll produce it commercially, then it will cost less than $200. So how do we make this so affordable? Because of our circuitry. Here you can see the circuitry we have developed. This circuitry and the power source, it makes the price of it lower. So here you can see the demonstration. Please run the video. Okay, so here you can see our demo patient who is affected of sudden cardiac arrest, and the analysis of his ECG signal. He is a normal patient. We have used him as a demo. So if arrhythmia is detected here, Bluetooth will transfer the signal to our prototype, and the circuitry of our prototype will generate the shock and produce the shock, and it will transfer the shock to the patient body through this paddle.
So we collected data from PhysioNet and local hospital. Based on this, we trained our ML model and differentiated between normal and abnormal ECG marked on raised box. We used Plam-Tompkins model and relative difference method to detect all 5 peaks and morphology of our parameters. It takes only 20 seconds to detect the arrhythmia and initiate our biphasic shock. The shock is shown here. And And you can see that the phase 1 and phase 2 shock is quite similar as the local AED. So here is our cost breakdown for per AED. The cost is variable as the human resource can be reduced if we make it more in numbers. So we have some limitations also. As it's very sensitive trial because the patient fights with life and death situation and needs quick response. So reliable components are not widely available also. So here is our future plan. We want to develop an simulation of electrical model of our heart, and then the animal trial and cloud-based data server will be developed, and we will develop our circuit and more powerful battery modification of our pad, and associated with doctors, the certification process is on the way. And also, we welcome interested investors from you.
You were talking about how it's automated and weight-based. Is your ideal setting in a hospital practice where the patient's weight is known, or is it also going to be used in the community where you may not know a patient's weight? And is there an option to set maybe an automatic joules for those patients?
You can put it manually on the display, or we can use a weight machine when where the patient lies. So it can take the weight automatically. The doctor no need to input that.
Okay. And then the second question in terms of pediatric patients, I don't know if you're planning your technology on including children and how that might change the size of the paddles and the way that it's used.
Okay, this is the demo paddle we have developed for our prototype. You have already seen that my friend has said that we will go for human trial in future. If the competition will take place after 6 months, maybe we will develop it further. Our main plan for children, and we have already said that it is basically a weight-based algorithm. So when it is a children, the weight will be less, and the pad size will be changed according to the children's physical morphology. So the pad you are seeing here, this is this kind of adult patient or for prototype only to see what we are doing to other.
Are you able to shock the patient with your lead still on the patient? So I saw you have the patient with the monitor leads to check for their arrhythmia, and then you have the paddles.
Yes.
Actually, we detected the abnormality, but the shock is not still given as it's still risky, and we need to have animal trial first.
So, no, I think what she was asking is, are you able to shock with the leads? Because currently the AEDs, you detect the rhythm with the pads, and you apply the shock so nothing ever comes off or on. But what you have currently, you have the leads to detect the arrhythmia. Do you need to pull those off before you use the paddles?
No, actually, there is the protection circuit, so it's not needed.
Let me clarify it further. We have a protection circuit here so that no burn injury can cause to the patient if any malfunction occur. Then we do not need to put out the lead because our first priority is accuracy and low cost, two things. The lead electrode here is using to collect the ECG data is not that much costly. That's why if this destructs due to shock, then no problem. We have to take the ECG data first, then if the electrode will be placed, then you have to take the pad first and push this separately. Yes, I know that the traditional AED that is found in local market has the sensor and the shock provider is in same pad. But since our main priority is to make it low cost, that's why we are focusing on the, it will be not a problem for the countries like lower income country to use separate sensor, one for shock and one for collecting ECG is not a problem. for them because we need to, our first priority is accurately saving life. Have you got it?
From Team Alpha, from Jomo Kenyatta University of Agriculture and Technology.
So thank you so much. And my name is Daniel Orinke, and I'll be presenting on behalf of our team, that is Team Alpha, from Jomo Kenyatta University of Agriculture and Technology. And we'll be presenting on our project, which is an innovation called the InsuBox Innovation. And these are cost-effective insulin storage system for better outcomes in diabetic patients living in low-resource settings. Next slide, please. So to our problem statement, according to manufacturer's recommendation, insulin actually requires to be stored at refrigerated conditions of 2 to 8 degrees. And these are around 36 to 46 degrees Fahrenheit. And temperatures below or above this can lead to actually loss of potency, leading to life-threatening diabetic emergencies such as diabetic ketoacidosis and hyperglycemic hyposmolar state. And also, poor sugar regulation can also result to insulin variations, and this can lead to chronic complications such as nephropathy, neuropathy, cerebrovascular diseases, and other conditions. Maybe the slides are a bit vague. Maybe you can assist us with that, please. Next slide, please. Okay, thank you. So to compound the problem further is that conventional refrigerators are actually very expensive, and the cheapest price in Kenya is around $250. And these are unaffordable for most households and facilities. We've also had organizations and patients coming up with cheaper and innovative options, as you can see in the screen. But unfortunately, these methods actually use unvalidated techniques and sometimes can lead to temperature fluctuations. Next slide, please. So currently, there's a high cost of electricity in Kenya and also in most other African countries, and this has contributed to poor utilization of electricity, whereby you find many households now just use electricity just for lighting. And as we know, refrigeration can be quite expensive in terms of power consumption, and that's currently it's unaffordable and not a priority for many patients. And out of all this, we're able to learn that the current context is that in many rural resource settings, especially in health centers and the diabetic patients themselves individually, they're not actually able to store the insulin as recommended. And these are a challenge that we have also seen in our clinical practice. Next slide, please. So out of this, we aim to bridge the electricity access gap by utilizing solar energy. We also hope to improve utilization of fridges by providing an alternative that is cheaper, cheaper storage system that is actually affordable to diabetic patients and in remote clinics in rural societies. We also hope to reduce insulin storage fluctuations through an automated system, which enables insulin to be maintained within the recommended regions. We also aim to ensure efficient power monitoring system through a prompt communication system that ensures that we are able to notify the patient, especially when the power levels are low. Next slide, please. So to our solution, it's called the InsuBox, and you can see it on your left. And this is just an illustration of the different components. So it's actually a dual powered. You can either charge it using solar energy or electrical energy. And you can also charge using the electrical energy. You can charge the battery. The battery is also connected to a voltage sensor, which is able to actually prompt the user automatically in case the power levels are low. And the microprocessor is actually programmed. We have a software that is programmed using a software. It's connected to a cooling system and a temperature sensor that is the cooling system. So once temperatures are above 8 degrees, it's actually able to switch itself on and cool the cooling compartments that is in the temperature ranges. And in case the temperatures go beyond 2 degrees, it's able to switch itself off. And the temperature sensor is also connected to an LCD display screen that actually shows you the current temperature readings. Next slide, please. So we've used 2 layers of styrofoam, which are quite thick, and also aluminum foils for insulation. And we have also been able to test for efficiency, and we've been able to see that it's able to maintain the temperature ranges all through when it is actually in power, and even 30 to 45 minutes when the power is off. So below is our table. We did a 3-day trial and just testing for efficacy. And we began at 6 a.m. and finished at around 6:30 p.m. in the evening. And then we were also able to test the temperature just 30 minutes after we switched off, and it was still within the required ranges. Next slide, please. So some of the advantages of InsuBox: one is able to maintain the desired ranges, temperature ranges for insulin storage, as you've seen. And this is through an automated prompt and feedback system. It's also able to have some colored bulbs and a buzzer to prompt the user in case the battery levels are low. And also, the battery can also stop us for up to 48 hours when it's actually in use. And it has a detachable solar panel with a long extension that can actually allow for suitable positioning anywhere. So the solar panel is actually continue charging as you use. We also have two batteries which are interchangeable to ensure that we have solar optimization. And it also has a shorter rechargeable time. This is for when using solar charge the battery around 6 hours. And also it is a bit light, it's less bulky and flexible, and can actually be used for quality transport of insulin and other medications that require cooling. So some of the limitations, currently it has some noise, but we're working on developing a vacuum noise reduction system to ensure that we're able to reduce this noise and within the styrofoam layers. And sometimes optimization of solar power is a bit difficult, especially during the gloomy weather, but we have a backup battery to actually counter this. So we also did a cost evaluation to just justify the cost effectiveness of the InsuBox. And out of all our costs, we're able to come up with a total of $66.3. And this was also accounting for some markup and an additional cost. And when we compare this with the current price for the normal fridges, the conventional fridges, which is $250, we find it that it's quite cheap compared to the normal. So to our scale up, we hope to refine and improve the design further. And after that, we hope to do some verification and validation studies. And thereafter, we hope to register it as an innovation with the health technology, starting with Kenya as our pilot. And thereafter, we hope to scale up the production, and we'll collaborate with the government, with development partners. We've already talked with some of them. And also we'll bring in the private sector. And with the government and development partners such as NGOs, we hope to lobby for incorporation into the healthcare systems and financing systems. And we hope that we'll use this to actually provide improve access, and this is through subsidized insulin storage that is within public remote clinics, and also cold chain transport, and also among diabetic patients who actually visit the public facilities. And with the private sector, we hope to partner with some of the companies that actually manufacture electrical appliances, that we don't kind of reinvent the wheel. We hope that we'll be able to integrate it into existing production systems. And through this, we'll be able to sell to the patients at lower cost and cheaper prices. So next slide is our team, actually showing our team with the team members, with our mentor. And the other pictures are some of our members as we are actually undergoing development of the InsuBox. So thanks so much.
Is there actual refrigeration, or are you merely starting with a cool insulin and an ice pack and attempting to keep it cool for a limited period of time?
So to our cooling system, it's actually actual cooling because we're using the Peltier technology. We also have a heatsink and also some fans. We're actually using the Peltier technology. It's actually actual cooling, not use of ice packs. Yeah.
Just maybe you can explain what that cooling technology is. It's not very clear in.
Okay, thank you so much. So for the cooling, we are actually using a Peltier. So like the Peltier is able to conduct heat transfer. So it's able to become cold on one side, and then it's able to transfer the heat on the other side. So on both sides, you also have fans, which are able to ensure that the temperatures which are inside the cooling chamber are actually maintained. And then we have a strong insulation system such that is made of styrofoam and aluminum, such that when cooling actually happens on the inner part, and this is connected to another heatsink, which is able to transfer the cooler temperatures to the inner part, and it's able to maintain these temperatures, the cooling temperatures. And then these, the temperatures, the heat is then transferred to the outer part where we have another heatsink, just transfer it further. And then we also have another fan that is connected to the outer environment to ensure that the temperature is controlled. Yeah.
Can you comment on what's the capacity and the intended use setting, please?
So, the intended use is that, so this is our, like the cooling device is actually shaped this way. I think you can see it maybe in the prototype, in the picture. So we have a fan, we have a heat sink. So we have two heat sinks, and then inside the heat sinks, we have a Peltier technology, the Peltier device, which is actually connected to a heat sink on the inner side that's within the cooling department. And then on the outside side, so this the outside side, we have a mesh to ensure that once it is drawn outside, the fan keeps on rotating, then it's able to drive the heat outside. For the capacity, it's quite big in terms of it can store insulin devices. Boxes are quite small, so it can store a lot. And we hope to use it for low resource settings, that is the remote settings where they don't have electrical coverage, and also in settings whereby the electricity prices are quite high. For example, in remote parts of Kenya. The good thing is that we really don't need power because we are actually able to use solar energy.
Thank you. How much does the insulin weigh that you put inside this chamber?
Okay, insulin, actually, like our insul box can store a lot of insulin. We find that the insulin is not that heavy. It's actually a syringe size.
Welcome Team TSH from Rice University.
We're Team Test TSH, and we designed a low-cost screening device for congenital hypothyroidism to be implemented in low-resource settings. Now, to give a little bit of background, congenital hypothyroidism, also known as CH, is a thyroid deficiency disorder that is present at birth and can lead to impairments in growth and development. Now, currently, 1 in 3,000 newborns born worldwide are born with CH, and only 60 to 70% of these newborns have access to screening. So what does screening look like exactly? In high-resource settings, such as the United States, basically, newborns are screened right at birth for a variety of congenital diseases, and one of them being congenital hypothyroidism. Basically, the blood is collected and sent to a statewide laboratory for testing. For congenital hypothyroidism specifically, the TSH, or thyroid stimulating hormone, is measured and compared to the threshold value of 20 millinternational units per milliliters. And if the TSH level in the infant's blood is above that level, then they are flagged for congenital hypothyroidism. However, this newborn screening program is not implemented in low resource settings due to its high cost and need for greater infrastructure. So a lot of infants in low resource settings go unscreened. For example, our clinical mentor, Dr. Tebow's patient, Catherine, she was born a healthy-looking baby girl. However, she started developing difficulties eating and poor organ functioning. And at 8 months, she was diagnosed with congenital hypothyroidism. However, at that time, it was already too late, and some of her symptoms are now irreversible. So in order to prevent the diseases from being irreversible in neonatal patients, it's important to design a low-cost screening device.
Our goal is to make our device fit for tertiary care centers to make this screening as accessible as possible for our target area of sub-Saharan Africa. Through our research, we identified these 5 key needs for our device. First, we want to minimize invasiveness by using less than 0.62 milliliters of blood for the testing, as this is the amount of blood that can be obtained through a newborn heel prick sample. Second, we want to minimize cost, keeping it under $1.50 per test. Third, we want to make sure that we are flagging as many positive cases as possible to avoid any delays in screening. Thus, we want to ensure our sensitivity is at least 90% around our threshold value. Fourth, we want to minimize the time until results to make sure that families can get the results within the span of their appointments. Finally, we want to make sure that our results are easy to interpret to minimize any need for external resources or extra training.
So in order to meet those design specifications, we came up with a solution that probably seems very familiar to you all. We actually drew inspiration from the COVID-19 rapid test to design a diagnostic that presents clear, easy to interpret results. So our test is a lateral flow assay, which is built using a nitrocellulose test strip that has 2 different antibodies dried onto it at the control and test sites. The blood sample is mixed with anti-TSH antibodies that have been labeled with gold nanoparticles. These antibodies detect and bind specifically to any TSH molecules present in the blood sample. When the sample is added to the test strip, it absorbs into the sample pad and flows through the test strip due to capillary action. Once the sample reaches the test site, the antibodies dried there they also bind to the TSH molecules, forming an antibody sandwich around the TSH. At concentrations of TSH above the normal threshold for newborns, the accumulation of these complexes result in the formation of a visible indicator that suggests that the newborn is at risk for CH. At the control site, a similar process happens, except that the antibodies actually bind to any other antibody, regardless if it has TSH. The formation of this indicator validates that the test is working as intended. We also 3D printed and designed a case to hold the test strip.
As Alice was mentioning, in order to read a positive result, we needed a line to appear at and above the diagnostic threshold. So in order to accomplish this, we needed to calibrate our line to appear only at the value of 20 millinternational units per milliliter and above. So as you can see on the left, here we sampled a variety of antibody concentrations to see which would provide us with this result. And then on the right, you can see that the concentration of 20 and above are the only ones that have that final dot on the very bottom row. So this shows that we are able to accurately distinguish between a positive and a negative sample. Another success that we had is in being able to reduce our cost. Our current cost is only about 10% of the current standard of care in the United States, and we believe that with mass manufacturing, this cost could drop even lower to around 11 cents per test.
Awesome. So now moving on to the limitations. We had two limitations with our preliminary testing. The first being the environmental factors in our target location. So we haven't gotten a chance to test with high heat and humidity settings. We also have not gotten to test with actual blood samples. So all of our blood so far has been artificially made in the lab. And so we're hoping to do clinical trials and real blood testing soon. And then moving on to our design, traditional lateral flow assays actually have their conjugated antibodies put into a conjugate pad on the strip. However, as Alex mentioned, we do store ours in the buffer solution used. This had no implications on the performance of the test, but it may affect long-term storage. And lastly, since we are using a plastic case, there is the potential to accumulate a lot of plastic waste. So we're hoping to explore different plastic options that can maybe be autoclaved and sanitized so they can be reused for each test strip. So moving on to our implementation, after testing and making sure that our device complies with regulations, we want to explore manufacturing with local partners, and we hope to adapt the existing infrastructure that is used to make COVID-19 tests. Finally, we want to establish local partnerships with vaccine clinics, hospitals, and ministries of health to ultimately reach the 70% of the world's population that does not have access to newborn screening programs. So yeah, in conclusion, our low-cost screening device is the missing puzzle piece to provide an early diagnosis to the infants born with congenital hypothyroidism in low-resource settings.
I didn't catch if you've been able to test the sensitivity of your assay. And the second part of that is 90% good enough, 90% sensitivity?
Yeah, absolutely. So we have been testing our sensitivity, and it has been operating at over 90%, but we are planning on scaling up our testing in order to get stronger statistical data. We would definitely prefer to have it as high as possible. The current industry standard is for sensitivity plus specificity to equal 1.5. So our target value of 0.9 would allow us to have a much lower specificity and still reach this value. Our ultimate goal would be to be as high as absolutely possible, but this is a general ballpark range that we got from industry standards.
And if you could speak into the value of the early detection, like does this lead to like diagnosis? Will they need to take any medicine or surgery?
So early diagnosis, so within the first 2 months of the birth of the infant leads to the best outcomes. So treatment is actually very affordable. So really the roadblock is in the screening. Once an infant is screened and identified as positive for congenital hypothyroidism, the treatment is really accessible. It's simply a pill of like thyroid hormones that they would take to make sure that their hormone level reaches a normal level, and then it will help to contribute to like proper growth and development.
I just wanted to add to that currently this timeline of the need for the diagnosis lines up with the timeline for mandatory vaccines, and the vaccination clinics are very widely used with about a 92% rate of, so we believe that this could be a very effective way to roll out our device.
My question is regarding that timeline, because in newborns, that TSH level can vary based on maternal thyroid conditions. I don't know if you've looked at like if somebody were to screen at 2 days versus 2 weeks, those variable results.
Yeah, so according to our clinical mentors, there's that brief period right when the infant is born where you actually can't really measure it because it's so variable. But between something like 24 hours and that 6-week mark, if it is below that 20 millinternational units per milliliter, then it is within that normal range. But when it reaches above that threshold, that's when there are risks that need to be addressed.
Levothyroxine, the hormone that the baby would need available in those settings? to treat the condition?
Yes, I believe levothyroxine is what the treatment pill includes when they're tested after they've been screened.
Just to add to that, so our clinical mentor has assured us that the treatment is actually very affordable and accessible. So again, really the roadblock is the screening. After that, treatment is easy to access, and even the treatment schedule is very achievable for infants.
Team Jager, joining us from Nigeria, from the University of Lagos and Federal Technical University.
Thanks so much for having us. Yes, my name is Moturaya Sonyalu. I'm a student of Electrical and Electronics Engineering in the University of Lagos.
I'm Timdoluwa in the Department of Mathematics, University of Lagos.
And our project is a solution to hypothermia in Nigeria and neighboring countries such as Niger and also the whole of Africa. Next slide, please. Okay, there is an adage in Africa that says, children are the crown of the old. Unfortunately, child mortality in Nigeria makes the crown too small and sorrow too great. Next slide, please. Next slide, please. Despite several efforts by MDG and SDG organizations in the world, child mortality still remains a huge problem across the world. And this effect is heightened in low-income countries such as in Sub-Saharan Africa and in Southeast Asia. Among these countries, Nigeria ranks second when it comes to child mortality in Africa. Next slide, please. This is a map showing the distribution of under 5 mortality across the world. Please. And this is the position of Nigeria on the map. Next slide, please. So preterm birth complications are estimated to be the leading cause for under 5 deaths in the world, in Nigeria. I mentioned that a direct implication of preterm birth is hypothermia. And hypothermia is very deadly because research has shown that it increases the mortality risk by 80% for every 1 degree Celsius decrease in temperature. Next slide, please. Okay, there are several methods to manage this condition, also prevent it. A few of the common ones are radiant warmers and incubators. However, these equipments, the purchasing price and the cost of maintenance makes the cost of use too high and unavailable to the general public. These equipments are also immobile and are not suitable for transportation. Fortunately, there is another method called kangaroo mother care, in which the baby is strapped to the mother and is warmed with the mother's heat. This method is cheap and effective. Next slide, please. However, it can be very costly on the mother's mental and physical health, especially in the duration immediately following birth. Next slide, please. Slide, please. Okay, so we came up with our aims for the project. The first one is to reduce neonatal mortality in Nigeria and in Africa at large, to provide a safe means of transportation for babies, to provide a cheap and easy way to warm babies, to replace incubators, and also to complement KMC. Next slide, please. Next slide, please. All right, so considering the objectives, we came up with our design criteria. A few of the notable ones are cost effectiveness, infant safety and comfort, and also rechargeable energy source. Next slide, please. Next slide, please. So Team of the University of Lagos came up with a design to solve hypothermia in Nigeria and in Africa. Our solution is called NeoBlanky, and NeoBlanky is a multifunctional, low-cost infant warmer. It is divided into 3 main components. There's the swaddle blanket, the heating unit, then the power and regulatory unit. Next slide, please. The swaddle blanket is the part that you insert the baby into. It also wraps around it and captures the heat that has been produced by the heating unit. It is made with some important components. There's the wool, the polystyrene, then the aluminum foil. Next slide, please. Moving on to the heating unit, this is the part that provides the heat that is necessary to warm the baby. It is made with a few components like water, cotton wool, then the nichrome wire. Next slide, please. There's the regulatory unit. It is the part that regulates the heat coming from the heating unit, and it is made with a few components like the microcontroller, the Arduino Nano, with Arduino code, then the temperature sensor, and also the relay. Next slide, please. Okay, this is a picture of NeoBlanky. You can see the swaddle blankets, the regulatory unit, and the room for the heating unit. You plug the USB into the power source, and it goes into the nichrome wire. The nichrome wire is heated up and transfers the heat to a mixture of water and cotton in the heating unit. Then there's a temperature sensor attached to the swaddle blanket that reads the temperature and sends it back to the regulatory unit. This part controls the relay and turns off or opens the circuit and closes the circuit as the need may be. Next slide, please. Next slide, please. Okay, after testing our products, we came across base potential for it. The initial heating from room temperature to 40 degrees Celsius took about 45 minutes. Then this temperature dropped only 3 degrees Celsius in 30 minutes. Then the reheating back to 40 degrees Celsius took 10 minutes. Next slide, please. Next slide, please. In terms of the price, NeoBlanky, the cost of making NeoBlanky was only $60 compared to its competitors like incubators and radial warmers that cost from $400 to $10,000. Then NeoBlanky is made from easily accessible and cheap materials such as wool, cotton, aluminum foil. It can also be used without any instruction from anybody. It is also very compact, so it can be used for transportation. Next slide, please. Next slide, please. We came across a lot of challenges while making this. The first one was finding a suitable sealant for the heating compartment, then getting a battery that can provide the amount of power that is needed to drive the device, and it's also small enough to be attached to the whole device. Then we had issues transferring the heat uniformly and also a lot of other challenges. Some of this we will not be able to solve fully yet, so we're going to work towards that. Next slide, please.
Next slide, please. Now, all we have done so far is a proof of concept. In future iterations, we are going to work on removing redundant components in order to reduce power consumption. We're also going to do more research on appropriate substitutes to the materials used so far in order to increase efficiency. A crucial necessity, for example, is a solar-powered charger, which will ensure sustainability. Next slide, please. The design of NeoBlanky is unique, efficient, and practical for its intended purpose. By paying attention to material, temperature control, and efficiency, we believe this approach has the potential to solve the problem of hypothermia, bedeviling millions and thousands of households in Nigeria and Africa and beyond. We are eager to develop our products and help families provide the best of care for their preterm babies.
They say health is wealth, and we are excited about our contribution to Africa's prosperity.
Is this device meant for hospital use or at-home use?
Okay, the design of this is something that both medical personnel and individuals can use. So it can be used in the hospital and can also be used in the home.
How do you keep the nichrome wire from becoming a heat hazard?
Okay. So the nichrome wire is inserted into a 3D printed box. It is layered, it is between two layers of water and cotton. Now this is coated with ceramic all through, so there is no way for the nichrome wire to burn through the casing, yes.
I don't think I heard your argument on why this when you have KMC, because hospitals in LMICs particularly are building KMC wards, and it's not just the mother, but anyone in the family can provide that warmth and comfort. So I couldn't understand that KMC argument. I mean, I would like you to explain that. And I don't know if this, have you tested for a long-term use of this device, the blanket on a baby, and whether that causes further allergy, and the safety hazard is what I think you were just addressing to with the wires as well. So great to hear your views on those two questions.
Okay. Well, the first part, the KMC is very effective and also very cheap, but we're considering the mother in this situation. A mother that has just given birth is not in the right state of mind, mentally and physically, to hold this baby. That might become a lot of stress on her, and she might not be able to keep up. So for the second question, I'm sorry, what was the second question?
Any allergies when you use this on a baby?
Okay. No, we have not tested this on a baby yet. This is just a proof of concept to show that the technology can actually work. So it has not been produced yet. It's just a prototype. the first iteration of the prototype.
Welcome Team Selyukov from the University of Rochester.
Okay, so hi, my name is Judith Monakraj. This is Dewey Doan, my partner, and we are part of the Selyukov Biodegradable Lateral Flow Assay team from the University of Rochester.
Our goal is to create a COVID lateral flow assay antigen test that can degrade in a non-toxic manner while maintaining low cost per unit with high sensitivity levels.
So when designing our device, we wanted to keep in mind that medical waste is a global concern, particularly impacting developing countries that may not have the resources to handle with such a large amount of accumulating plastic. And so we prioritized our device having a degradation time that is within 6 months. We wanted the device and all its degradation byproducts to have a toxicity that is less than or equal to 10 parts per million. And finally, we wanted our device to have a familiar appearance to similar COVID tests that are currently on the market to aid in user friendliness and minimize any medical mistrust. Some of the wants that we also had for our device include a shelf life that is comparable to current tests on the market, around 1.5 years, a cost of production around $1 per device to increase accessibility, and our test to produce a result within 15 minutes of a sample being placed on it.
So our proposed solution is to keep the current design of existing COVID tests while replacing the materials to biodegradable ones. As you can see on the screens, these are the preliminary designs of our test cassette and the vials that contain the buffer solution. So we use this polyhydroxybutyrate or PHB plastic as the main material to create our cassette and our buffer vials. For our test strip, we replace all the nitrocellulose and fiberglass materials with cellulose-based materials for biodegradability. On both ends of the strips, you can see they are the sample and absorbent pad, which are made of wood pulp sponges, and the membrane pad we have are made of cellulose-based material that allows lateral flow assay and antibodies to adhere to. Our litmus and cellulose proof of concept control and test line are here to test the capillary action of our test strip. And encasing the whole test strip is the PHB cassette. We have also replaced the desiccant with nano charcoal in paper bag, and the instruction manuals will be printed using algae ink on water cellulose paper.
So some of the successes that we've had so far with our device as we've entered the prototyping and testing phases have included the fact that we've seen some proof of PHB degradation. In a test where we placed a PHB disc in artificial seawater containing septic bacteria, we saw the dissolved oxygen concentration decreased by 1 milligram per liter over 1 week. This is proof that the bacteria are degrading the PHB for nutrients and using the oxygen within the test. Additionally, we've done some mechanical testing on our device, and we've found that it is more brittle than other plastics, which assures us that natural mechanical forces would also help aid in degradation.
So it comes to our knowledge that we have limited time and data for the testing phase. As you can see on the graph, we have seen signs of degradation for the mass loss over time, but we need further data to have a better overall understanding of the total degradation time of our devices. Cost is also a problem since our goal is $1 per device, and the current production cost is $1.50 without cost of regulatory and distribution.
Some other limitations that we've had in creating our device have included the buffer solution. A lot of buffer solutions contain toxic and non-degradable chemicals, such as sodium azide within a COVID test buffer solution. Additionally, our tests would could be stored in a Connex storage container that can often reach temperatures of around 135 degrees Fahrenheit. However, COVID tests need to stay in an environment that is around 36 to 80 degrees Fahrenheit to maintain test functionality and the antibodies.
So to sum up, we have successfully created a proof of concept lateral flow assay device. We have also seen signs of degradation as the decrease of 1 milligrams per liter in the dissolved oxygen concentration. And we have seen changes in the surface roughness of the laser confocal images. And for our future plan, we want to continue our testing to have a better overall understanding of the total degradation time of our device. We would also want to test the ability to adhere gold nanoparticles on cellular-based material to convert our proof of concept test into a functional biodegradable COVID test.
Additionally, as we would look at mass manufacturing and distributing our product worldwide, we looked at different cassette designs that could be more adaptable for US septic systems or flushable. We believe that our test would go through FDA approval, as seen with the LIA flushable biodegradable lateral flow assay pregnancy test that is currently FDA approved and on the market. Additionally, we'd look at functionalizing carbon dots that are biodegradable to replace the non-degradable golden nanoparticles and antibody tagging. And finally, we'd look at overall reducing manufacturing costs.
And we would like to thank the professor and faculty members from University of Rochester and Rice University in helping us with the project.
And now we'd like to open the floor to questions. Thank you.
So have you used this in a head-to-head trial with existing COVID tests? And how do they compare?
Yeah, so we have not not had enough time to go through the full degradation process of our product yet. And the technology that we would plan on using in this device right now is this same antibodies as the chemistry as a current COVID test. In the future, we would look at replacing those golden nanoparticles, but for the most part, the test should work the same way as a regular COVID test. It's just the plastic and test strip components that would be changed.
Just asking, do you have the data if someone had COVID and they used your test, is it positive if they used a commercial test? But I applaud you trying to make a small change in what we already have to decrease the overall trash in the world. That those tiny small changes that we make huge changes overall. So.
I'd also like to applaud that. I think it's very important that you're working within a system rather than trying to develop something completely new. But I really don't understand, maybe I just don't hear well, are you developing your own new biodegradable plastic? It seems like the biodegradability of the plastic should be separated from the problem of developing a new COVID test.
We are keeping the current design of existing COVID tests, but since most of the component of current COVID tests does not biodegrade, we want to replace those components into biodegradable materials.
I understand, but can't you rely on the fact that you know they're biodegradable already, so you don't have to test their biodegradability independently?
Yeah, so a lot of our data was working on the specific filament that we are printing our tests in. PHB is biodegradable. We were also testing how all of these components would biodegrade in the septic environment. Our plan is, or our intended disposal of the device would be, it would just be disposed like in landfills or in a septic system. And so we just wanted, that is the main testing, not just degradation, but degradation in the intended environments you'd be disposed of.
Degradable plastic is not a new topic for many of these companies. So did you pick off some of that intel already?
So thank you for your question. So to answer the first part, for manufacturing ability, so for our prototype, we 3D printed it, but we have talked to people that companies that we can injection mold it, the PHB cassettes to reduce the overall cost. Throughout material selections, we have talked with the Mango Incorporate company that do the injection molding of the PHB, and we also have
there's also a professor at our university, Dr. Meyer, who's one of the lead researchers in PHB, and our university works with Mango Materials that does a lot of mass manufacturing and injection molding of PHB.
Yeah, and finally, to add on that, we will test the ability to adhere of the gold nanoparticles or quantum carbon dot to detect COVID on the membrane pad, because currently they're printed on the nitrocellulose. So we want to test how our cellulose-based material can adhere the gold nanoparticles.
Colleagues joining us from Malawi, good evening to our colleagues from MUBAS with Team Poiesis.
My name is Brenda Mwari, and mates are I'm Katie Ansambo.
And I am Peter Ndawa.
And we are from the University of Malawi, the Polytechnic, which is now Malawi University of Business and Applied Science. And we are going to present to you our project, and our team name is Poiesis. And to start with a problem statement, in low research settings like Malawi, there is high patient to nurse ratio, which causes nurses to have or look after more than 30 patients at a time. So because of this, nurses can't manage to monitor 30 patients at a time, which can lead to overhydration or underhydration of a patient. And due to this, it is our project will be able to meet the unmet need of developing a device that will be able to help nurses administer and monitor the amount of fluids that are being administered to patients. Currently, nurses are using IV, which is gravity-led, where they manually administer the IV fluid and manually set the time, and also they manually set the time and manually count the drops being administered to the patient. Thereby, due to the fact that the process is being done manually, it can lead to technical difficulties such as overhydration, since if the nurse has administered the IV fluid at a rate that is slower or faster as the intended time, then it will harm the patient by overhydrating them or underhydrating them. And our proposed solution is an IV drip controller designed to improve the accuracy of intravenous fluid administration and hence patient therapy, and enhance the patient therapy. Basically, our device is coming in to improve the accuracy of administering IV fluid here in Malawi, because nurses are administering IV fluid using gravity-led infusion, which is done manually and which can also lead to errors while doing administration. And our main objectives are monitoring and controlling the flow of IV fluid in a drip and measuring the volume of fluid that is in the drip and also administered to a patient. I'll take you through the existing solutions. In the existing solutions, this helped us to find the gap of our project or how to tackle our project, since there are already other IV drip controllers on the market. The IV drips that are on the market are expensive when it comes to a low resource setting like Malawi. Most of them range from $500 to $1,000, which when you convert to Malawian kwacha, it's 500,000 to $1 million kwacha. And also these are difficult to operate, so they need extra skills for them to be operated here in Malawi. And also it requires a lot of maintenance and trainings. Another issue is about power outage. So in Malawi, we have issues with our power sources. So most of the power supply that uses these monitors are AC or DC, which is hard to operate here in Malawi. So with these disadvantages from the existing solutions, we're able to find a gap that will be solved by our solution so that it applies to the Malawian setting. We hope that our solution brings an impact where it reduces the over or under infusion of a patient, and also provide a capacity to supply IV fluids at a precise rate set by the nurses. And also to make it possible for people to administer IV medicines at home without being monitored by nurses.
This is group 3 voices, and this is our IV drip controller. We managed to do the monitoring, and this is how it works. We have the user interface, menu, up, down, OK. And this is our display. This is our default screen. So if you want to monitor, you click menu. You select whether you want to monitor or control. So if as we want to monitor, so we press OK. And then you choose the number of drops per milliliter that you need. We use 10. As for now, it has started detecting the drops. So
How is the volume of the drip actually measured by the prototype you've shown us?
okay, so after choosing the number of drops that you're going to administer in a second, then in a minute, not in a second, sorry, in a minute, then it is able to calculate after detecting the drop rate. If you're administering, let's say, 10 drops in a minute, then our device is able to calculate that if there's 10 drops in a minute, then let's say in an hour, then it will calculate how much the volume is being administered to the patient regarding to the number of drops you're administering. And because there are choices, or let's say there are options where the nurse or the medical personnel will be able to choose. And if the medical personnel chooses 10 drops per minute, then with time, the device will be able to calculate the number of or the volume itself administered to the patient.
And to add what my friend has said, the device has 4 drop factors, that is 10 drops per milliliters, 15 drops per milliliters, 20 and 60. So once the user chooses, say, 20 drops per minute, then the device will make calculations, so that once you have 20 drops, you should assume that that is 1 milliliter. So therefore, it counts until the amount of fluids ends as we are administering the patient.
We will now turn to our colleagues from Queen's University, who will present on their ultra-portable ECMO machine.
Hello, everyone. It's an honor to be here with you today. My name is Julia. This is Noah, Emma, and Darian. And this year, our team has undertaken the task of building an ECMO machine, which is also known as an artificial lung. And with that, we are very excited to present to you our ultra-portable ECMO machine. Please feel free to pass around our 3D printed membrane during our presentation.
So what exactly is ECMO? ECMO stands for extracorporeal membrane oxygenation, which is an artificial respiration technology that augments a patient's cardiac and respiratory system function. In a typical ECMO setup, deoxygenated blood is taken from the patient's body via a drainage cannula inserted into the femoral vein. It's circulated by a pump through the oxygenator membrane, which our judges are passing around, and then is returned to the body, generally by the superior vena cava, to be recirculated through the body where the oxygen is then delivered by the blood to all the cells. The deoxygenated blood then recirculates back through the drainage cannula. ECMO is currently used in clinical applications such as acute respiratory distress syndrome, COVID-19, and sudden cardiac arrest.
Currently, ECMO is limited to major healthcare centers and requires multiple specialists in order to operate the device. The unit cost alone of an ECMO machine is over $120,000 US.
Please raise your hand if you know a friend or family member who has suffered from cardiac arrest. Each year, over 300,000 patients suffer from cardiac arrest in the USA alone, 33.6% of which occur in the southern region.
Our main objective is to serve remote and underserved communities around the world to ensure equitable healthcare delivery. Currently, out-of-hospital cardiac arrest has a survival rate of less than 10%, and this is heightened in remote areas which often don't have timely access to major healthcare centers. When it comes to cardiac arrest, every second can mean the difference between life and death. As a result, studies have proven that if ECMO is applied within 20 minutes of the onset of cardiac arrest, the survival rate actually increases from 8 to 29%. Therefore, if EMS had access to ECMO on site as well as en route to the hospital, ultimately more patient lives would be saved. As a result, our design emphasizes being portable so that it can be easily transported. It can be affordable so that it can be implemented in low-resource communities around the world. And finally, be durable so that it can be reliable for use in any condition.
With these three design criteria in mind, the physical subsystem houses all of our components for the ECMO device. We opted to use an off-the-shelf wheeled Pelican case to ensure that, and foam lining, sorry, to ensure that the components inside are protected from any environmental impacts. In addition, we've opted to use 3D printed materials, like we're passing around, for ease of replaceability in the field between patients. Finally, all of our physical subsystem encompasses all of the functions of the device you can see in the top right into the size of a small carry-on suitcase.
The gas transfer subteam is where the deoxygenated blood comes to be oxygenated. So our custom-made triply periodic membrane, which is being passed around, it increases the blood oxygen transfer capabilities up to 69.8% when compared to traditional hollow fiber membranes. The membrane is 3D printed using VeroClear resin, and it's housed in a waterproof 3D printed casing, which you can see in the top left of the screen.
The entire system is regulated by an automated control system. The data is transferred via Bluetooth from the sensors to the display, where we can clearly see blood temperature, flow rate, oxygen concentration, and carbon dioxide concentration. The bottom row of cells allows for target values to be inputted by practitioners to update machine settings.
In the center of the screen, you can see a top-down view of the ECMO device with the foam padding removed. In the top right of the screen, you can see the membrane that we were passing around, and in the bottom, you can see it mounted within its casing. In the center of the screen, you can also see other components such as the power supply, sensor control boards, heat exchanger, pump, and of course, the membrane itself. Going back to our three design criteria, our design meets these criteria by being portable, being, like we said, small enough to be carried on an aircraft. It's also only weighs 20.2 pounds, so light enough to be carried around by one person. It's affordable, having a unit cost of only $1,500 and a per patient cost of only $300. This could be further reduced by mass production. And finally, it's durable. It's able to be used in the harshest conditions and is able to be dropped, not fully immersed in water, but it is weather resistant, and it's able to be used even in dusty environments. Oh, back to Julia, sorry.
All good. Although our team is very proud of the performance of the current design we have presented, these are the steps that we will be taking to improve our design further. For starters, we will be testing the biocompatibility of the materials incorporated to ensure that all the invasive components don't cause adverse effects on human blood. We will also incorporate a system to alarm practitioners if any of the values are outside of the normal ranges. In further iterations, we hope to add a system to cool the blood as well as inlets for IV drips to administer medication. To validate and test our design, we will be calculating the gas transfer efficiency of our lung to ensure that the oxygen exchange rate is between 0.25 to 0.4 liters per minute. Next, we will determine the mean time between failure and conduct drop and impact tests to ensure that the device is durable. And finally, we are excited to upscale our design and implement the ultra-portable ECMO machine in healthcare settings around the world so that people suffering from out-of-hospital cardiac arrest, those living in remote areas, and your loved ones' chance of survival increases.
When we put people on ECMO, either VV or VA ECMO, it's usually done by a cardiac surgeon using ultrasound in a sterile field, and then you have a perfusionist to run the ECMO machine because it takes a lot of adjustment. So how do you guys plan on being able to use this in a field in a critical situation?
Yeah, so that's a great question. And to combat that, we have opted to use, likely anyways, use femoral access, so femoral vein, femoral artery access, which is something that's within the scope of practice of, in Ontario at least, of advanced care paramedics. There was also a study performed in Paris that used in the field ECMO, and we used that as some of our data, where we saw that it was improving patient survival odds from 8 to 29%. That was conducted by a team of specialists, so it was, I think, one cardiothoracic surgeon, one perfusionist, and 2 nurses, along with a team of paramedics that were a rapid response team within the city. So they would drive to the site of the arrest, administer ECMO, and then they would be transported by other paramedics. So it would really depend on the situation, but either one of those 2 protocols could be used. Does that answer your question?
Yeah, information was transferred by Bluetooth, and in those very remote settings, if you don't have that available, or is that an issue if there's...
The system is designed to work with the display. So if you don't have access to a display, there are default settings, but those settings aren't going to be correct for everybody when you plug, you can't just attach it and use ECMO with a small child and a large, adult. It's not going to be the same. So a practitioner does need to update the settings when you use it, but there are default settings already there, worst case scenario. But, if you want the full functionality of the machine, to be able to see what the temperature, the flow rate, and the actual oxygenation rate is, you're going to need a display.
I just had a question about the practicality. If you're implementing this in an emergency situation in low resource, how are you going to get the blood and ensure that there's no antigen mismatch or typing and all of that with the patient?
Yeah, so this isn't a blood transfusion device. It's only recirculating the patient's own blood. So it wouldn't be used as a replacement for a transfusion technology. That would be something separate, and it's something that's available in current ECMO devices.
Team Save the Children from Bangladesh University for Engineering and Technology, please join me in welcoming Samiha.
Hello, and a warm welcome to everyone present with me today. We're Team Save the Children from Bangladesh University of Engineering and Technology, and we're honored to have this opportunity to present our project with you all today. So today, we would like to bring your attention to a serious medical condition of newborns called neonatal apnea. So what is neonatal apnea? Neonatal apnea occurs when a newborn baby stops breathing for more than 20 seconds, leading to respiratory failure, developmental delays, neurological damage, and in some cases, death. While visiting the neonatal ICU departments of the hospitals in Bangladesh, we were moved by the large number of preterm babies struggling to survive. We saw that in the case of neonatal apnea, there is no instant solution to it in absence of caregivers. And there is also a shortage of healthcare professionals and reduced affordability in developing countries like Bangladesh. Also, the late and inaccurate detection and monitoring of existing devices put the lives of the newborns at risk. Therefore, the challenge is to develop a low-cost and accessible solution for general people in low and middle-income countries that can detect apnea with higher accuracy and provide instant primary care to the neonates. Tragically, 62,000 newborns die in Bangladesh annually, with 1/3 born premature. Globally, the number is 2.5 million neonates, and neonatal apnea accounts for up to 20% of it. And in sub-Saharan African countries, the rate can be as high as 50%, which is heartbreaking. From a prospective study of 50,826 neonates, we can see that in the case of preterm infants, the infant mortality rate is with multiple apneic episodes was 58%, and with single apneic episode was 18%. And in the case of full-term infants, the rates were about 44% and 5% respectively. So one potential tool for monitoring neonatal apnea is the pulse oximeter, which measures the oxygen saturation level in the blood. But it has some limitations, like it cannot detect the apnea when the baby moves. And while using phototherapy, it can interfere with the infrared lights. Also, the ambient light and electromagnetic signals can corrupt the signal often. And even if it can detect the apnea, it cannot give an instant solution to it. Now, Natalia will continue.
Okay, am I audible?
Yeah.
Yes. Our system is based on 6 principles: affordability, accessibility, reliability, simplicity, safety, and portability. It's designed to provide low-cost and easily accessible medical care for newborns, particularly in low-income and remote regions, while ensuring reliability and accuracy. It's also user-friendly, safe, and portable, allowing for users in both home and hospital settings. Here is our initial blueprint of the device. The control unit houses our microcontroller and the buzzer. The chest belt has an accelerometer inside which detects the chest movement while breathing. The cannula has 2 thermistors attached to it which detect the temperature of breath. And here an anklet has a vibration motor which gives the neonate the primary care. And here is the prototype we built according to our design. And here's the demonstration video.
This is our control system, and this is the chest belt where we have an accelerometer, and here we have 2 thermistors attached to the nasal cannula and 1 vibration module attached to the baby's feet. So the accelerometer here detects the chest movement of the baby, and the thermistors detect the temperature difference between the environment and the nasal airflow. So when we see that there is chest movement of the newborn, we can see the iteration starts over. But when there is no chest movement, we can see the iteration goes on. And also, in the case of thermistor, if there is nasal airflow, we can see the iteration starts over. But if there is no nasal airflow, the iteration goes on. And if we have no chest movement and no nasal airflow, then the iteration goes on, and it counts up to 20 seconds and gives an alarm. So it gives an alarm, and also the vibration module attached to the baby's feet vibrates because the passive limb movement can regulate the breathing rate. And when the situation becomes normal and the newborn has a regular breathing rate, then the doctor can come over and press the switch, and the iteration starts over again, and the system restarts.
During normal respiration, the chest moves back and forth, and accordingly, we get rhythmic curves for all 3 axis acceleration. Otherwise, the acceleration signals remain constant. For normal breathing, there is up to 3 degrees Celsius temperature difference between inspired and expired air, and we get a sinusoidal curve for airway opening temperature, while no breathing gives a constant graph. Thus, the nature of the temperature graph can also identify apnea periods. Breathing temperature can be used as an additional signal parameter for monitoring.
Our device has the potential to revolutionize the way neonatal apnea is monitored and treated. It can give precise detection by combining the spatial movement data acquired by accelerometer and the temperature difference data acquired by thermistor that helps to detect apnea with higher accuracy and reduced errors. And after detecting, it can give an instant protection by the vibration on the sole of the feet that stimulates the joint proprioceptors and increase the breathing rate. So here is an overall cost analysis of our device where we can say that through mass production and the use of cost-effective components like Arduino Nano, the cost of the production could be less than $20, which is highly affordable. So there are several successes of our device, like low cost and low power consumption, and we can monitor the babies continuously by automated algorithm, and there is higher accuracy as we are using 2 sensors. It's non-invasive, it's user-friendly, and there is no interference from external lights and motion. As we are still in the initial stage, there are some limitations as well, like the thermistor sometimes might take a little more time to respond, and there's a possibility of false positive alert, and there's a constant need of the close proximity between the sensor and the neonat's body. So in the future, we have plans to use highly sensitive thermistors, add a mobile notification system, develop a novel machine learning algorithm for analyzing the data more accurately, make the device rechargeable using a battery, and if we succeed at accomplishing these goals, we are ready for clinical trials. So we believe that our device can reduce neonatal mortality rates all around the world, especially in underdeveloped countries. And we're excited to continue developing our project and making further improvements.
Is it one computer per baby?
When we'll do that, then no need of computer.
And the alarm?
The alarm is built with a microcontroller. It's in the control unit. We have a microcontroller in it and a circuit in it, so that gives an alarm.
Near the baby or near
No. That is from the baby.
It would notify the...
So they would get notified and can come as early as possible, because the apnea can cause serious damage if the time gets more delayed and delayed. So.
Do you need both the nasal cannula and the accelerometer data to detect an apnea?
Our targeted users are mostly premature babies who have nasal cannulas. So in their case, we are planning to use 2 sensors for higher accuracy. But it can operate with 1 sensor as well, but the accuracy might be a little low. So, yeah.
Can you explain the foot sensor again? Is that to detect?
No, the foot. In the foot there is no sensor. There's a vibration module in there, so that basically gives an instant primary care. So that after talking to a doctor in the neonatal ICU department, we got to know that they flick the baby's foot or like give a message, like. So we are implementing the vibration module here to give the artificial flickering or the vibration. So in this way, they can they can be instantly cared. Yeah.
Team Pathfinder. Team is from Ladoke Akintola University of Technology, also known as LAUTECH in Nigeria.
Good afternoon, everyone. My name is Patrick, and I'm representing Team Pathfinder. We're from LAUTECH University in Nigeria, and I'll be presenting alongside my teammates who are joining virtually. And today we'll be talking about DOPAN, which is a disability-inclusive sanitary system that was designed with additive manufacturing. So what's the problem? Globally, 9% of the world population practice open defecation. That's about 673 million people. And out of the world's population, 3.4 billion people live in rural communities. And 48% of those people use the basic sanitary system, that's the pit latrine. And out of that, 48%, 28% have an improved sanitary system. And so we want to solve, we want to design a solution that will put an end to open defecation globally, because, for example, in Nigeria, back around August, there was a flooding in eastern Nigeria, and a lot of people were displaced, about 2 million people. A lot of children suffered cholera, and there was a rapid disease flow in the IDP camps. And so we want to design a solution that will be inclusive and still solve the problem of poor sanitation. So we considered 3 design rationales, and that's accessibility, providing a solution that is inclusive to everyone, and a solution that is cost-effective, because it takes about $100 to $150 to construct a 2-piece toilet like in Nigeria, and it takes about 3 days to do that. Imagine doing that in a situation of health emergency. And the ease of production, we have a global goal to end open defecation by 2030, and we need to construct about 143 million toilets to do that. And so we need a solution that can produce these facilities with ease. And so our target users are people with disabilities and also the adolescent girls, because it is hard for them to use most of the toilets because of sanitary conditions, and then they end up going to the bush to ease themselves, and then that could expose them to potential dangers like violence and rape. And so my team, we came up with a design, and that's DealPan, which is an improved latrine system for people in rural and refugee settlements. It has a physical support for people with disabilities and a hand wash apparatus that will reduce the risk of infection. And let me start it up. Okay, so this is DealPan. It's installed in an already existing pit latrine, and you can see the handrails. You can see the platform that will hold the wash apparatus. And beneath, you could see a trap door. It closes like a flap, so that odors can't emit from the pit, and it just uses a closing mechanism. You don't have to do anything. And when you flush, the fecal material goes in and it closes back up. And so the main feature includes the self-closing trapdoor, the plastic handrails for support for people with disability, and the fecal pathway. And what is our successes? We've been able to design a simple, hygienic, and accessible sanitary system, and we're able to test it in one of the communities in Lagos State, and it was able to carry a person of average of 160 pounds in weight. And it has it's mostly made of propylene and handles. The handles are made of propylene plastic, and the total cost of production is just $9. That's very cost effective and can be produced in large quantities in a short time. And what are our challenges? We are currently using plastics which are not biodegradable, but through our research and our testing, we found out that this is the most suitable material to be used based on the ease of cleaning and the durability of the handles. We hope as we further develop this project, we will be able to find a better and a more biodegradable material. And then the other challenge we've had is that, especially in Africa, there's a belief that when ladies drop the sanitary pad, it could be used for voodoo. So we are still trying to find a way to make this facility safe for the girl child. And we hope that by 2025, there will be massive adoption of DealPans that will reduce the global open defecation to about 20%, because with the ease of production and the low cost, we can be able, in the next 7 months, be able to produce 1,500 DealPans a day. And we also want to provide a female-friendly toilet in schools that would reduce the prevalence of dropout rates among the females. And this is my wonderful team. We're made up of, we have a great team balance, people from different backgrounds, and Tawheed, this is me, Patrick, Victoria, Emmanuel, and John Cooker. We have a background in engineering, in software development, in content creation. You gotta meet my team, it's so beautiful. And so there's, we just wanna provide a solution that could help people, especially people in marginalized communities. And we want to use DealPan as a catalyst for health, dignity, and social inclusion. Thanks.
Thank you. A very urgent need, obviously, but have you compared your solution to other solutions here, very innovative solutions out in Africa, like Sanergy, which is also looking at establishing toilets, but they also use the human waste for recycling. So just curious, how does your solution benchmark against some of those solutions?
Sorry?
Thank you kindly. Basically, we have come up with a disability inclusive action system for the disabled and those that live in the rural environment. The existing latrine system is in existence, it is not durable, and it is not cost effective. So we have come up with a disability latrine system, and with just $9, this can be produced, and the use of plastics which are biodegradable, collaborating with community actions against plastic waste by getting plastics from scavengers, plastic production company, and whereby we are going to produce more plastics, get more plastics from that place, and we are producing a circular economy by turning a waste to waste. So that is the solution to the challenges we are going to be encountering in the plastic sector.
Thank you. Another question is, you mentioned that the current toilets take 2 days to make, or 3 days to make. How does your device compare to the production of another latrine? I think you just highlighted the pan side, but the toilet part, but not the.
Okay, our solution is meant to be used especially in marginalized communities and places like the refugee camp. So the normal two-piece toilet takes about 3 days to construct, but with our solution, it's going to be installed in already existing pit latrines. Most of this camp already have pit latrines, but ours make it easier for people with disability and also for the girl child. So it can be easily placed on a platform. So this is like a prototype we have. So just a normal concrete slab, you just put in the DO pan.
In addition to what Patrick has said, this particular project is channeled towards 2 SDGs, SDG 6, which is clean water and sanitation, and SDG 4, quality education.
Now we will welcome Team Lil Pap from Georgia Tech.
Hi guys, we're Team Lil Pap, and we present to you the multi-pap. Okay, so it's devastating that 1 in 8 babies are born premature in low-resource countries and consequently suffer from respiratory distress. 1/3 of these neonates are primarily die because of respiratory distress syndrome, which is where their alveoli are not able to remain open by themselves. And since the lungs are the last organ to develop in babies, they often need CPAP, or continuous positive airway pressure, to maintain the pressure in their lungs and prevent their airway from collapsing. So in our user interview stage, we talked to a respiratory therapist who often worked in Tanzania, and he told us once he had 3 babies in front of him, and he could only save or just focus on one struggling baby at a time and couldn't save them all. It would have been really helpful to have a machine that can support multiple neonates at once. And in high-resource countries, currently, CPAP is the non-invasive standard of care. However, there's a lack of sustainable and all-encompassing CPAP devices in low-resource areas that provide heated and humidified air. And we address these needs by developing a CPAP device that provides neonates with treatment, and not only one, but multiple, and does so by preventing hundreds of thousands of neonates from dying. And so we looked at several predicate CPAP devices, including the ones you guys see here, like the Fisher and Paykel and Seattle PAP. But the one that we learned from most was actually the Pumani, which was developed right here at Rice. It has had tremendous success by being able to deliver bubble CPAP to neonates in an affordable and simple manner. And building off the success of the Pumani, we've added the capability of adding heated and humidified air, while also supporting multiple neonates, further decreasing the cost per neonate.
Sorry. More than just looking at predicate devices, we spoke with respiratory therapists, global health practitioners, and in-country healthcare providers with experience in scores of countries around the world. From these conversations, we learned what the design considerations for a device should be. We start by looking at the design inputs, and we want to protect the fragile airways of the infants. So an air provided needs to be between 34 and 41 degrees Celsius with a relative humidity of 85%. Additionally, the pressure created should be between 5 and 8 centimeters of water pressure, and that should be generated from 2 to 10 liters of flow per minute. Furthermore, our device should be able to work in a wide range of environments, from the jungles of Cambodia to the highlands in Ethiopia, and we can't assume that there'll be any climate control. Another variable will be the supply voltage. This could range from 110 to 240 volts in an outlet in a district hospital to a 24 car volt battery that you'll find in a rural clinic. But beyond all of these design specifications, we needed our device to be compatible with the users. So it needed to be easy to clean, simple to use, easy to fix, and durable. Thus, we give you the multi-PAP, a bubble CPAP machine that can generate heated and humidified air to multiple neonates at the same time. And the reason that we chose bubble CPAP is because bubble CPAP, which generates pressure by submerging a tube that pushes air against water, it's the simplest and the most accessible in these low resource environments.
So we created the multi-PAP with a unique and custom tubing system in order to support the combination of heated and humidified air and supplemental oxygen going to each neonate. So there are 5 main components that make up our CPAP device, including an air pump, flow control valves, a custom-made humidification chamber with a temperature feedback system, a patient interface or neonatal nasal cannula, and a water pressure chamber. So the flow throughout our multi-PAP starts at the air pump. The air travels in through the passover humidification chamber where it is heated and humidified. Simultaneously, the oxygen enters a tube in the humidification chamber where it is heated by the water through convection. The oxygen line is then split and the flow rates for oxygen are adjusted according to each neonate's prescribed treatment. The airflow is also split and combined with the oxygen, or the airflow is split and then combines with the oxygen and is delivered to the interface through the inspiratory limb. The other side of the nasal cannula or patient interface is attached to the expiratory limb, which is submerged in a water pressure container. So we conducted 2 main experiments in order to validate our prototype. The first experiment we conducted is the pressure variability experiment, not the temperature variability experiment. And this experiment was conducted in order to ensure that adjusting treatment for one neonate did not affect the treatment and pressure being delivered to the other neonate. The second experiment that we conducted is the temperature and humidification experiment in order to ensure the efficiency of our custom-made humidification chamber.
So from our testing, our pressure variability testing, we validated that the pressure aligns with submersion depth. Similarly, in our temperature and humidity testing, we validated those corresponding design inputs. A limitation of our device is that when adjusting the flow control valve to differ the treatment to each neonate, there are some fluctuations in the air and oxygen flow rates. We will compensate was this by having a range of FiO2 levels available in the manual and initial device setup. Additionally, we have a problem of condensation buildup in the tubing. This is very common with CPAP machines that use heated and humidified air. We will combat this by adding tubing covers, insulating the device container, and raising the neonate relative to the device. We plan to manufacture our device in the US using off-the-shelf components in a custom-made humidification chamber. We will continue to do durability and safety testing. This is necessary when we bring our device up to the FDA for 510(k) clearance and to the ministries of health in our target countries. After successful implementation in Cambodia and Zambia, we will continue to validate our device to be able to support more than 2 neonates at once. With the success of these goals, we are confident that we can provide low-cost, life-saving respiratory support that meets the demands of healthcare workers and neonates in low-resource environments. The price of a life is immeasurable. Let's save 2 at a time.
What is the oxygen source, and are there any limitations to what oxygen source it can work with? Yeah, so the oxygen source, our machine is compatible with just an oxygen tank and also an oxygen concentrator. And there is a limitation with the FiO2 percentage that we can provide, and that is up to 70%, and that is based off of the combination of our flow rates for our device setup.
But you can do anything within that range from 70% all the way to 0%. So you could have no oxygen and still be able to provide sufficient bubble CPAP.
Thank you for your presentation. I had a question. Is the heated and humidified air shared between the patients, and is that an infectious concern?
Yeah, so that is something that we have thought about, and we include antibacterial and antiviral filters on each of the inspiratory limbs going to each neonate. We have yet to test those, but...
And additionally, we're heating and humidifying the air before we split it. And so because you're having the just flow going in one direction, that would do the most in mitigating any spread of disease.
Did you present information about wonderful presentation, but did you present information about costs of these components and I just missed it? Or?
No, don't show it. So right now our calculated cost is about $220 with the over-the-counter off-the-shelf components that we're using, and then our custom-built containers. So With that, we need to adjust for the manufacturing costs in the US and then implementation in country. But as a humanitarian device, we want to keep that cost as low as possible. And then also, we want to appreciate the fact that we're supplying this to multiple neonates at once, and that will also decrease the cost per neonate.
Team Stark from the University of Lagos in Nigeria.
What is Incubed? Incubed is a cost-effective incubator for low-income regions. And next slide, please. Yeah, next slide. Next slide, please. Next, sorry. So, according to research, we found out that the major cause of global neonatal deaths is hypothermia, and hypothermia is a condition whereby the neonates lose more heat than they can absorb, and we all know that this is because of the body fat to surface area ratio. And the recognition of this need in the 19th century led for the invention of regular incubators that we know today, and they've proved to be very effective in Western regions. Next slide, please. So this is a map showing the under 5 mortality rates as at 2020, and it shows 37 deaths per 1,000 live births in Nigeria. And we can even see regions that have 150 deaths and above in sub-Saharan Africa. Next slide, please. This is a chart, and it's just showing that the neonatal mortality rate as at 2022, and we can see that Nigeria's was about 2 times the average neonatal mortality rate, and almost 20 times more than that at Monaco. Next slide, please. So why is this gap so wide? What's the thing that Africans are lacking? My team made a couple of researches and we're able to come up with 3 problems. Next slide, please. So the other slide. First, it was the cost of living. We noticed that we tried to compare cost of living for Nigeria and that of an average American, and we noticed that there's a very wide gap. And we also have issues with budgeting in low-income countries. The budgets that is allocated to healthcare sectors are very small, and the funds are even poorly mismanaged. Please, next slide. So we also have the issue of electricity. I think almost all the teams here that were trying to solve low-income problems talked about the issue of electricity, and it's a very big issue because we know that incubators have to be kept on to maintain that ambient temperature of about 34 to 37 degrees Celsius. Next slide, please. So the last problem was the lack of technical expertise, and I think Dr. Teresa mentioned it in her talk, and she was about to say, this was a picture we took at Lutz recently, as at last year, and we noticed that the incubators just kept getting piled up, and there was nobody to fix, nobody to maintain the incubators. Next slide. So what was our solution and how did we approach? Next slide. We knew that our design had to meet 4 requirements. It had to be cost effective to ensure that even the basic primary healthcare centers can be able to afford it. Then it had to have a backup power supply to checkmate the issue of electricity in Nigeria. Then it had to be simple to use. Nurses shouldn't have issues to use it. Then if there's a fault, our local technicians should be able to fix it easily. And we also had to implement an air filtration system so that we don't jeopardize the baby's health. Next slide, please. So next slide, please. Our first ever model was designed around the fact that we're going to change the heat source from regular incubators to beeswax. And beeswax is a very good heat retainer. And although we could not move on with it because we were not able to even test the viability of beeswax, and the material wasn't ready. And that's a 3D model showing the drawer and how we plan to use beeswax. Next slide, please. So this is the current CAD design of our design, and this is what we use to build our prototype. Next slide. So I'll be going through the working principle. I don't know if my teammate is already on the call on the chat, but
Hi, Dara.
Okay. Hi, Ife. I'll just wrap this up and you just continue. Is that fine?
Yeah, sure, it's fine, it's fine.
Okay. So for our model, we had three basic systems that we had to solve, and that was one was a cooling system. Our cooling system consisted of two brushless fans, 12-volt brushless fans, and filter layers to ensure that the air that is coming in and going out conventionally had to be clean to the smallest micron. And our heating system was replaced. The normal heating system in regular incubators made use of heating filaments, and we thought of ways to make it cost effective and also efficient. So we used nichrome heating elements. It was submerged in wax, rather cotton wool soaked in water. Please, can you go to the next slide? So we have thank you. So this is like a diagram showing our heating system, and it's just basically taking the steam from the steam chamber, passing the perforated layer and going into the baby's chamber. Next slide, please. So this is a card model, but the steam chamber covering is open, so you can see the nichrome heating elements that we used, and the perforated layer is the bronze layer. Next slide, please. So this is our model showing the three systems. And next slide, please. So for the software part, we try to automate everything using Arduino. We used an Arduino Uno, and this code basically says that the output devices, which are the heater and the fan, should be turned on and turned off at certain threshold temperatures. And we're able to test this, and it works. Next slide, please. Okay, so this is just a link to the repository of our code. Next slide. My teammate Ife is going to take it from this place. Thank you very much.
Okay. So, can you hear me?
Yes, I
we
can.
can.
Okay, good evening, everyone. Okay, my name is Ajayi Folua, and I'm a member of Team Stack. So, talking on the challenges, we faced several challenges while we were working on this project. We didn't include everything else. Like one of the challenges that we faced was the time constraints, and the fact that we, the members of the team, were fully like in the health sector. We had one of us who was an economic student. I was studying health education. It was only that same in line with like we were studying medical engineering. So we had to do a whole lot of reading and research outside of our field of work to be able to come up with this. And then figuring out the eating system, which was the major part. It took us a whole week to come up. And for those who came up with this project in the span of like 4 weeks during our internship at the Unilag Design Studio. And then that challenge we faced was downscaling the size of the incubator, because when we cut out the material, it was way too big and we didn't want to waste material. So we had to reduce the size, and then unavailability of some materials. Like Dara first said, the first material used was beeswax. Because we were not able to come in contact with that, we had to go back to the drawing board and look for other substitute. Next slide, please.
Thank you so much, Ife. I want to make sure we leave some time for questions. Is there a final thought you'd like to share before we open up the floor to questions?
So we know that, like, in conclusion, we've not been like with this project that we know it's not the final one. This is just our, like, will I say, the first iteration of our project, and we're looking forward to working with other companies and other bodies that are interested so we can make this market ready. So far, what we've been able to do is just to get a relative humidity of 70% and then get the ambient temperature which is required for the baby's chamber, and that's all. Thank you very much.
Since the bottom half, your heating chamber is using so much water, I wonder if you are worried about infection, just from that being there and then having to be changed often and cleaned up by hospital staff.
Yeah, that was one of the things we talked about. It's not exactly, I mean, like there's not going to be so much water. It's just enough. The water there is just enough for like to
Damp,
and
to dampen
produce to dampen the nichrome wire and just produce steam. And we also plan to include like a inlet and outlet so they can easily like put in water and pour it out for that to make it easier for them. And like this is still like a work in progress. We not exactly got into our final designs. We believe that as time goes on, we definitely find something better for that one.
We are so pleased to have our colleagues joining from Georgia Institute for Technology with presenting on their work, Wear Your Helmet.
Hello, everyone. My name is Victoria Brown, and I'm here with my teammate, Andrew Bonner. We're Team Wear Your Helmet, representing the Biomedical Engineering Department at Georgia Tech. Next slide, please. About 25% of the world population suffers from soil-transmitted helminths, commonly known as STH. STH is a parasitic disease transmitted by eggs in the human feces when contaminated in the soil in poor sanitation areas. Next slide, please. STH is categorized as a neglected tropical disease, which is commonly found in countries in sub-Saharan Africa and tropical Asia. The STH infection is found to cause a loss in 3.3 million disability-adjusted lifespan years, posing a significant cost in poor countries. Symptoms caused by STH includes diarrhea, severe stomach ache, along with problems in physical and cognitive developments in children. Next slide, please. Currently, the standard method lab technicians use to identify STH prevalence and intensity in communities is called the CATO-CAS protocol. This protocol includes manual collection, preparation, along with examination of the stool samples done by lab technicians, often in rural settings, including with lack of resources such as electricity. These limitations of the protocol include inconsistent spread of the samples, along with if the thickness of the sample is not thick enough, it can cause dark coloration, which makes it hard to read the samples. Next slide, please. Other teams have taken on this problem, creating other devices that makes it easier to count the eggs presented in a sample shown on the slide. However, complications included by these devices was due to the uneven surfaces in the area, along with lack of electricity. That's why our team decided to take another approach in tackling the preparation aspect of this problem. Next slide, please. Our device, the stool stomper, is a preparation device used to help lab technicians prepare slides so that each sample is pressed with a uniform pressure, ensuring that the sample spread is standardized before analyzing under the microscope. Next slide, please. Our device is included into the CATO-CAS protocol, meaning that the lab technicians will follow the same steps. However, instead of manually pressing the samples, our device, the stool stomper, will press the sample to standardize the spread. Next slide, please.
Our device took into account several design inputs from our users throughout user interviews. One of the main things our users pointed out was that the sample should be approximately 1 millimeter thick, leading to our cap design and shape being that of on the right. Furthermore, they stated that the sample should take about 120 seconds for 2 samples to be prepared. We implemented a strategy using a removable slide carriage in order to meet these needs. Next slide, please. Additionally, taking into account the 1 millimeter thickness required, we calculated that 0.69 pound force are required out of our spring system, leading to the design created on the right. And one of the main things they emphasized was that due to the use of stool in the process, the device should be easily sanitized quickly and often. It was stated that Dettol was the most common use or common method of sanitation, and we used PLA specifically because it does not degrade under heavy use of Dettol. Next slide, please. We were able to travel to Dodoma, Tanzania, and work with the lovely people at BMH Hospital in order to obtain the following results. One of our main successes was egg count consistency. In a random trial in which 14 samples were evaluated and prepared both by hand and via the stool stomper, 60% of the time, the stool stomper led to a more accurate and more consistent count, which can be seen in the charts below, demonstrated by the wider spread of the violin plot. The blue ones are the stool stomped in this case. Next slide, please. Furthermore, we obtained timing data and slide preparation time for all of the lab technicians using both the hand pressed and the stool stomper, as can be seen in this chart. The timing data indicated that the stool stomper decreased the time of preparation or kept it very close to the hand press slide. Next slide, please. Another way to visualize this data is through this chart as well, showing both the overall average indicated by the two bar charts, as well as the different points on the two bar charts. This indicates that an average time to prepare the slides decreased by 8.5% across all lab technicians when preparing samples via the stool stomper. Next slide, please. Some limitations were that the stool was pressed incorrectly via our first cap. So we had to make a new square cap with a heavier center of mass in order to correct for this. Next slide, please. Some future plans are to make this cap more robust and improve upon this design, as well as to combine the stool stomper with imaging software in order to create automatic egg counting capabilities, dramatically reducing the lab technician's time in the field. Next slide, please. A special thanks to CWW, Dr. Narcissus, Betty, and the lab technicians at PMH. Thank you very much. And if you have any questions, please let us know.
I like the idea that you're building this into an existing protocol, so it makes a lot of sense. I have a couple of questions. One, you said 60% of times it showed increased effectiveness in your Tanzania study. Talk about the 40% where it didn't, and how do you ensure that it's consistently the 1 millimeter thickness? Is there a built-in that it doesn't kind of go lower than that? How do you ensure that consistency? I may have missed that. Thank you.
So the stool stomper is designed to only be able to be pressed to a certain height, which would allow for the 1 millimeter of thickness. Unfortunately, when we were testing in the field, we realized that the sample needs to be spread a lot thinner, which was why we utilized a wider and heavier cap on the bottom in order to account for it can still only be pressed to the certain the certain height, but it now spreads it a lot thinner, allowing for us to standardize for both the force applied as well as the spread.
And then the 40% she wanted.
So the 40% of the other trials were very close. I'm not sure if we can go back to that slide. So each sample was from the same stool sample and then prepared both by hand and by stool stomper. So as you can see in sample 6, for example, there is a very distinct spread between stool stomper as well as hand pressed. However, in sample 1, it appears that hand pressed is a little bit wider, indicating a better spread for that. However, we had only about 6 to 5 samples, or excuse me, reads per preparation method per sample. So in order to create a more accurate picture, we would ideally have more reads per sample. So to kind of answer your question, while only 40% right now indicate that hand press is better, we hope to get that number down through replication.
You mentioned that the method of sanitation was the Dettol, I believe. Are you literally cleaning the 3D printed piece, or is it gonna have a cap or something like that?
Yeah, if you go back to the slide that shows our actual stool stomper design, Our device is actually detachable, so everything can come apart along with the spring. And then because it was 3D printed and PLA is able to be cleaned with Dettol along with bleach, because I know a lot of countries in that area, they use Dettol or bleach to clean their devices when using the KatoCast protocol. So we wanted to be able to include our device into the protocol and have them use the same resources they use now to clean their supplies.
And the device never comes in direct contact, ideally, with a stool sample. However, slips and other mishaps may cause it to come in direct contact with stool sample. So the magnetically locked plunger can come undone, and that can be washed very regularly if that needs to be, as well as the whole thing is made out of PLA. So at the end of the day, if a lab technician wants to wash the device, they definitely can do so, don't worry.
Clemson University, and that's Clemson Medical Devices for Low-Income Countries.
Hello, we are a team of bioengineers from Clemson University. Our project addresses the need for affordable dynamic prosthetics in low-income countries. Of the 40 million amputees in low-income countries, only 5 to 15% are able to receive prosthetics. High-performance prosthesis can cost upwards of $1,000, a purchase price which is simply not achievable for all. Current prosthetics, such as the Jaipur and Satch's foot, do not allow for ankle motion and can lead for improper gait mechanics and further injury. Based on feedback from our collaborators at the Indian Institute of Technology in Delhi, previous prototypes for affordable motorized prosthetics were too bulky and stiff in the ankle joint, which meant they were prone to failure in wet environments. The majority of these amputees are within working ages of 20 to 50 years old. For these people, physical labor is an essential part of their life. Their prosthetics must be able to endure India's agricultural environment, such as dirt, water, and heat. When working in prosthetics that do not cater to the demands of their environment and lifestyle, complications can arise, such as pressure sores and dermatitis. Therefore, there is a need for an affordable ankle prosthetic that allows for a dynamic motion of the ankle joint and is durable enough to withstand the environment and active lifestyle of farming communities in low-income countries.
Our solution is inspired by the normal foot and ankle system, which includes an arched foot and an articulating ankle joint. The ball and socket design provides movement in the sagittal plane, meaning forward and backward, and the frontal plane, meaning side to side. The muscle wire, a nitinol-shaped memory alloy that controls and extends when activated with electrical current, is placed in spring form along the joint to absorb shock and pull the foot into different positions. And the pressure sensors attached to the sole of the prosthetic observe foot position and communicate with the prosthetic's microcontroller to emit a responding current that is conducted through the muscle wire. Flex sensors are also placed on the edges of the sole to detect uneven pressure distribution when walking on uneven terrain and allow for corrective motion of the ankle joint. These sensors will be protected by a layer of foam on the bottom of the prosthetic. Current low mobility prosthetic solutions cost upward of $500. All components in our design have been carefully selected to endure the elements, be easy to set up and repair, and keep the cost low by sourcing parts locally. Our current cost estimation is less than $100. Our prototype was designed and rendered in SolidWorks, and the kinematics were evaluated with Simulink and compared to current ISO standards for ankle prosthetic devices. The force, stress, and cyclic loading analysis determined that the design is capable of withstanding up to 9,000 newtons of force with a lifetime of approximately 2 years. This is a promising outcome since walking, running, and jumping all result in forces less than the threshold in a person of 150 pounds, which is the average weight of an Indian male. Oh, that's cool. While the longevity of this device is shorter compared to non-mobile solutions, the muscle wire is the only component that would require replacement every few years, and we are hopeful in finding ways to improve the wire's durability.
The nitinol muscle wire is responsible for the dynamic motion of this prosthetic, and it must produce a sufficient force in order to move the foot when it's electrically stimulated. So we did mechanical testing on the muscle wire in its normal state and under supplied voltage to stimulate its effectiveness and performance. And based on this mechanical testing, a stress strain plot was acquired. And based on this stress strain plot, the muscle wire exhibited mechanical properties and is able to withstand the required voltage needed to replace a motor in an ankle prosthetic. For the pressure sensor component of our prosthetic, the optimal placement for these sensors were determined by referencing FEA analysis of plantar pressure distributions, and then these were translated to our current prosthetic prototype. These pressure sensors were placed along the bottom of a 3D printed prototype and coded through an Arduino circuit to coordinate points of low, medium, and high pressure during a stimulated gait cycle. And these sensors will then stimulate a specifically selected electrical voltage to pass through the muscle wire, causing it to contract. This then pulls the foot into dorsiflexural motion toward the shin and plantar flexion away from the shin. So our next phases with our prosthetic, one of our next phases is will involve investigating the change in length for the muscle wire in response to varying voltages needed at each phase of the walking cycle. And this is to achieve our desired angle of flexion during our normal walking cycle. Another phase of our project is we're currently 3D printing with a TPU filament, which is very stiff. So we want to move towards a more flexible and nylon-like material. And we want to continue looking at the physical gait analysis studies, and we're doing this with our partnership through IIT Delhi. And we'll keep working with implementing of the flex sensors to adhere to uneven terrains. And then we're also looking at comfortability, durability, and enduring through wetness and heat and things like that. And we're also looking to converting our Arduino circuit to a PCB board for better integration.
Some of your follow-up is to see if this prototype works like underwater, like the initial picture you showed where the people are walking in water.
Yeah, so we're going to be moving into durability testing soon. And so we're going to be testing on water, soil, to make sure that the pressure sensors can read on soil and to make sure that the electronics will be able to endure being in water. We're looking to place all the electronics on the pylon, like shin part of the prosthetic. So it'll be like a little bit above the water. And then we're going to look into encasing it in a water-resistant, waterproof polymer.
So patients with prosthesis have a difficult enough time just walking on level surfaces. How do you think they would do in unlevel submerged surfaces?
Well, so that's kind of the point of the function of this, is to make it easier on all terrains. So ideally, they wouldn't have a difficult time on flat surfaces, and they would have an easier time, and they would be able to even attempt to walk in underwater and these very challenging surfaces as well.
And our combinations of pressure sensors along with flex sensors should give an optimal pressure map that should help with any terrain.
So I have a question. Is there a device that you're kind of measuring to as a gold standard in terms of performance and how it should work or is this kind of breakthrough brand new?
For specifically implementing the nitinol muscle wire, that's definitely novel, and there isn't a lot of literature to go off of that, because muscle wire has been used in hand prosthetics before, but it's never been used in a foot prosthetic. So that's kind of where figuring that out. And with the pressure sensors and kind of gait cycle stuff, we're using that based on our partnership with IIT Delhi and their research, and also current prosthetic models and how just their mechanical properties and their how they work in the gait cycle.
Brighter Breaths from Case Western University.
I'm Daniil, and this is my teammate Kai, and together we are presenting Case Western's pediatric pulse oximetry team, Brighter Breaths. As recognized by the World Health Organization, pneumonia is a leading cause of death in children under the age of 5. In a recent study in this age group, approximately 14%, or 900,000 deaths, occurred from pneumonia alone, 84% of which occurred in 30 countries. These deaths could have been prevented if these children had access to proper diagnosis that was quick and effective. However, roughly 30% of children that were diagnosed, roughly only 30% of all children with pneumonia were diagnosed with pneumonia by the IMCI guidelines. For reference, these are what the IMCI guidelines are. They are a set of practices based around respiratory rate, as well as the age of the child. However, many are now many are now concerned with the effectiveness of these guidelines. Dr. Ganesh, a doctor at Cleveland Clinic a doctor at University Hospitals in Cleveland, ran through a systematic review of 119 papers regarding the diagnosis of pneumonia, and what he discovered is that within that, there is no clinical sign that is as accurate to diagnosing pneumonia as hypoxia, which can only be determined by pulse oximetry. So with that, 20 to 30. For example, with that statement, 35% of when pulse oximetry and oxygen therapy were implemented in Papua New Guinea, there was a decrease in pneumonia, but the decrease in mortality of pneumonia was 35%, which would translate to approximately 120,000 child deaths that could be averted if both pulse oximetry and oxygen therapy were readily available. The only problems with, and they might be wondering, why are pulse oximeters not as commonplace in these countries? And for that, we have 4 key reasons. The first is that it's an unstable probe design, whereas if you look at the top, it uses tape, which is expensive and non-reusable. And the standard pulse oximeter tends to break after 6 months. Another problem is that the probes could be too big for the child. Standard pulse oximeters, if you were to place a child's finger there, would leave a lot of extra space where ambient lighting can come through, affecting the result. There's a problem with long lead times, where if the time for taking a result is too long, it's deemed ineffective because they need to take in more patients, but if the time takes too long, they can't treat everyone. And finally is the cost. So in collaboration with Makerere University in Uganda, we were able to determine 4 key requirements. First one being durability by minimizing the mechanical parts and implementing a rechargeable batteries, which is what they explicitly requested from us. We want to create a probe that's able to be placed to areas of high perfusion. In our case, we'd be creating a device that could be placed on the forehead of a child. The lead time should be less than a minute, preferably less than 30 seconds, and the cost should be lower than any pulse oximeter cost out there.
Do you want to do that? All right, yeah. So as Daniil said, the idea is that it's going to be used on the forehead. So in this picture on the left, that's a picture of our housing design, and the part that's face down on the table, that is the part that will go on the patient's forehead. The orange part is what contains the electronics, and then at the top where the hole is, that's where the OLED is going to go. You can see to the right, that's a cross-section of our device. So it starts at the bottom, which is where it's placed on the forehead, and so there's infrared and red LEDs there that send light into the tissue, and then this is reflected based on the amount of blood, the amount of oxygenated blood, and then it's picked up by a photosensor, which is sent to the PCB, which really consists of an analog front end that's doing some signal processing, and then this is sent into a Arduino Pro Mini. We're using that one as well. I know another team mentioned that, and so this is what's running the algorithm, and as the results are calculated, it's displayed at the top so the caretaker can see it easily. And then all of this is run by a rechargeable battery, and you can see on the middle picture, that's the charging port, the plan for the location of the charging port. So I mentioned before that it's reflected light, so this is, I just want to point out, this is a different sort of technology than for what's typically used with pulse oximetry. So most pulse oximeters use transmittance pulse ox, which is the light is going through the tissue and it's detected on the other side. But in order to be able to do this on the forehead for pediatric use, we're using reflectance, which has posed some interesting design challenges. So just to go over what we've been able to achieve, we have a functional analog front end, and obviously the LEDs and the photo receiver working. We have a draft of the heart rate and blood oxygen algorithms. We have the housing design that was on the previous slide, and we also have a motion testing platform, which is meant to simulate the movement of a baby that you might be trying to take a reading on. And we want to make sure that our device will still work in those cases, because motion artifacts can cause a lot of problems. That was a major need identified by Dr. Ganesh as well. And we also have the medical grade silicon interface for the forehead.
So with some of the limitations, we've run into a problem where previous generations of the team would give us results, but not necessarily the steps or data on how they got it. So being able to build off that has become a problem. Skipping to the varying clinical settings, for like pulse oximeters, what we determined is that it's really hard to do a lot of needs-based assessment on the ground because certain hospitals or health clinics want different things than other ones. Not just solely about pulse oximeters, but it could be like one needs pulse oximeters while others need personal protective equipment. So there's just a lot of variation between what exactly each hospital needs. So it's hard to determine what exactly we need to do for this pulse oximeter for entire general population.
Yeah. And just finishing off with what our future plans are. So as like the studies from during COVID showed about pulse oximetry not working on darker skin tones as well. We want to add one solution to this is adding a third wavelength of light, which can be used to calibrate for melanin content.
Thank you. I'm particularly pleased to see that you're talking about previous and future generations of the team, because I think a lot of times it takes more than 1 year to develop these things. Is it well understood how a green LED can compensate for melanin in the skin?
Yeah, my understanding is that compared to the other wavelengths, like the infrared wavelength and the red wavelength, green is more, I think melanin absorbs it more readily than the other two. I think that, or it's either that or it's reflected more.
But it remains the case that you would have to have a calibration procedure.
Yes.
Thank you.
And am I correct that most of this, as far as actually measuring TCPO2, is theoretical, that you haven't actually gotten to building a prototype that includes measuring oxygenation?
Yeah, that's correct. The current situation is we don't have something that measures it right now. This is kind of what Daniil was alluding to with the previous generations. Like, there's like pictures of like, oh, like we achieved this before, but we don't know how they did it, and it's hard to communicate with these people. Yeah, because they've graduated. It was like a senior design project, and those people graduated, and like we're just left with like what we can find from what they did.
Team pH Perfect from Rice University.
Up to 43.5% of nasogastric tubes are misplaced in infants, causing severe complications and infant death. Hello everyone, we are Team pH Perfect, and we aim to reduce this number by creating a technology that can verify NG tube placement in infants before each feed in low resource settings. Preterm infants cannot feed normally due to underdeveloped digestive systems. Therefore, they need a nasogastric or NG tube to provide nutrition. The NG tube is inserted through the nostrils, down the esophagus, and it ends in the stomach, and milk or formula is then inserted into the tube. But if the tube is misplaced in the lungs or in the upper GI tract, it can cause severe complications, such as pulmonary asphyxiation, which can lead to infant death. Moreover, in low-resource settings, hospitals are understaffed, so they would benefit greatly from transferring this task to mothers. But the problem is that mothers are untrained, so they don't know how to verify NG tubes, NG tube placement. The problem is that current methods to verify NG tube placement require extensive training, such as auscultation, where you inject air into the NG tube and you listen for a whooshing sound in the stomach, or aspirate color analysis, where you pull out aspirate from the NG tube and you analyze its color. But these require a very subjective analysis and are very qualitative, and again, they're hard to train for in mothers. That's why we set out to design an accurate, reusable, and intuitive device that can help mothers verify NG tube placement for their infants in low resource settings. More importantly, our device is quantitative, and it relies on a pH reading because the stomach has a uniquely acidic pH that can confirm placement here. We wanted to design a device that was accurate within 0.25 pH units, that was reusable for about 6 months, and that was intuitive enough for mothers without any medical training to use. Additionally, it needs to be cost-effective for low resource settings, require minimal disinfection time, and be handheld.
In order to meet these design criteria, our team developed pH Pal, which is a battery-powered, accurate,
an intuitive method for NG tube verification in infants, and it caters towards those low resource settings. Specifically, this device uses pH readings to inform user direction sent back to the user that is taking care of their baby. It accompanies these directions with an LED display that uses a stoplight color mechanism to maintain its intuitiveness. To use the device, the user will first remove an aspirate sample from the infant's NG tube, as shown. The user will then place the sample into this aspirate collection tube of our device. The user then simultaneously inserts the blue pH probe and the silver temperature sensor into the aspirate collection tube to obtain a reading. Once both instruments are inserted, the user will obtain an accurate temperature-corrected pH reading within a matter of 3 seconds. This pH reading will not mean much to many medically untrained mothers or other caretakers, however. We have therefore implemented user directions on LCD display and the stoplight LED user interface, as I previously mentioned. Specifically, gastric aspirate in infants typically has a pH of less than 5. To be absolutely certain that the NG tube is correctly placed in the stomach, we have therefore implemented a pH cutoff of 4.5 or less to return a solid green LED with a command for the user to feed through the NG tube. If the pH of the aspirate sample is between 4.5 and 5.5, we cannot be certain that the NG tube is correctly placed, so the user is returned a solid yellow LED with command to retest or obtain another aspirate sample. Finally, if the pH is above 5.5 of the aspirate sample, we can be reasonably certain that the NG tube is not correctly placed and it could be in the upper esophagus or the lungs. This can lead to serious complications, as Sophie mentioned. So we return a blinking red LED to the user with a command to retest with a command not to feed through the NG tube, and the user can now get medical help. Following this measurement procedure, the user can simply wash both the pH probe and the aspirate collection tube with water and return both elements to their magnetically secure locations on the side of the device, and pH-Pal is ready for its next use.
So why use pH-Pal? First, pH-Pal is extremely accurate with small aspirate volumes. Across 40 tests using 1.5 milliliter samples of solutions of varying pHs, our device averaged an error of only 0.017 pH units. This ensures that our device will reliably be able to help a user determine whether or not the NG tube is correctly placed within the baby's stomach. Secondly, pH-Pal is affordable. Assuming our minimum device lifetime of 6 months, our device has a per-use cost of only 4.5 cents. This is 4 times cheaper than purchasing individual pH strips. Third, pH-Pal is intuitive. Across 10 tests with untrained users, all 10 successfully operated the device on their first attempt, taking an average of only 41 seconds to do so. This represents an important step towards our end goal of allowing mothers to perform this critical task in low-resource settings. Lastly, pH-Pal is portable. Our device weighs only 0.49 kilograms, the same as a can of Campbell's soup, and can easily be carried by hand. So while we have created a successful prototype, we've identified a few key areas for future work. First, we plan to integrate the pH probe and temperature sensor into one combined probe, allowing us to further minimize the aspirate volume required by our device. Secondly, we plan to custom design a PCB to house all our circuitry, allowing us to improve the durability and manufacturability of our electronics. Third, per the recommendation of a pediatrician, we plan to research other potential applications of our device, such as for detection of gastroesophageal reflux disease. Overall, pH-Pal is an accurate, simple, and reusable solution for verifying nasogastric tube placement in infants and low-resource settings. We hope that this will improve detection of misplaced nasogastric tubes, ultimately reducing infant mortality worldwide.
I like the intuitive nature of the design with the red, yellow, and green. One thing that I think might be a little bit difficult is the form factor and the usability of having to have a separate device that has to have a few steps done. And I would suggest that maybe all of that could be incorporated into a syringe that could be directly connected to obtain the aspirate and built into the syringe are your indicators. And then you simply rinse the syringe out with water.
For NG tube placement with infants, you really want to make sure it's below the lower esophageal sphincter and proximal to the pylorus, a lot of time babies have a high incidence of gastroesophageal reflux. So even if you're in the esophagus and you had the pH probe above it, I think you would still get a very low pH. And just distal to the pylorus, you're still dumping acid into the duodenum, so you would still have a low pH even though you're not in the stomach. So those are just two things to think about.
Hi, I'm a little bit worried about cleaning and sanitation of the little holding area of the pH tube. And just because it's like really tall, I think it will be hard to see whether like mold is built up in the bottom.
So we kind of saw this concern, and for the, I didn't really mention this in the cleaning process, but there are threads on the cap. So you remove basically the end that's actually holding the sample when you are cleaning the device, and you can wash both out separately.
We'll have Team Fistula Fighters from Washington University in St. Louis.
All right. Hello, everyone. We are the Fistula Fighters from Washington University in St. Louis. And our global health technology is centered around helping women with vesicovaginal fistulas. I'm Sam. These are my teammates, Trin and Savannah. And we are all seniors in biomedical engineering at WashU. These are our collaborators, Dr. Christine O'Brien of the WashU BME faculty, Louis Wall, who is a OBGYN and creator of the World Fistula Fund, Dr. Tracy Spitznagel, part of the WashU School of Medicine, Department of Women's Health. So let's first introduce you to this problem. Vesicovaginal fistula is an abnormal opening between the bladder and the vagina that results in continuous urinary incontinence. As you can see in the figure, urine can leak from the bladder directly into the vaginal canal and then subsequently out. This forms during obstructed labor when the mother's contractions cause the fetal head to press on the pelvic bone. This leads to loss of blood flow to the surrounding soft tissues, which results in tissue death and fistula formation, which is just a hole. This is rare in developed countries due to healthcare, but it is very prevalent in Africa and South Asia, where the ability to get maternal and emergency healthcare is limited. Currently, 2 to 3 million women live with this condition worldwide. They are often rejected by their partners, shunned from their homes, and isolated from their communities. As you can imagine, this leads to a high prevalence of depression and suicidal thoughts in this population. Thus, there is a need for women living with vesicovaginal fistula as the result of obstructed labor. They need a way to re-enter society without experiencing extreme humiliation, isolation, and stigma due to uncontrollable leakage of urine through the genital tract.
The first part of our proposed solution is an external urine collection cup that's a shallow silicone funnel that aligns with the user's vulva. And there's the addition of a thickened rim so that it can fit more securely in place. We created our initial prototype by first designing the cup and then using that design to make a PLA mold. We were then able to mold the silicone ourselves, and this was really helpful in our preliminary testing and modeling because we were able to account for the variety of anatomies in the vulva to best fit it. So our initial iterations of the cup itself have added a thickened rim so that it fits better to the vulva, a thickened cup itself so it doesn't compress under the weight of the woman when she's sitting, and then an extended funnel so that it collects urine more efficiently. And then this external urine collection cup is housed in a biker short. So the cup sits in the center crotch of the shorts, and then there's a hole that connects it to tubing that is on a tract on the side of the leg, and that connects to a urine bag that's in a pocket on the leg. The shorts are compressive and high-waisted to support the pelvis where the tissue may be weakened or due to prolapse.
So ultimately, we want our device to seamlessly integrate into the lives of these women so that they can perform their daily tasks and reintegrate into their communities. So just to walk you through a typical day in our shorts, every morning our shorts can be assembled in just 5 easy steps. And then after that, they're ready to go. Our shorts can be worn under a skirt or any loose-fitting pant without being noticed to allow for some discretion. And then once they're on, the women can bike, walk around, and just exist in their communities comfortably. Our shorts are made of a compressive nylon spandex blend to, again, support the weakened muscles in the pelvis. And then in the crotch of the shorts and in the tubing tract and in the pocket that houses the urine bag, this is lined with an antimicrobial moisture wicking fabric to keep any areas that may encounter leakages dry. Lastly, our device does not include any software components because it is meant to be worn in more rural areas, so we want to make sure that it works remotely without any extra technology. And then our bag can be worn for about, the shorts, can be worn for about 4 hours at a time, or until the bag is filled. Our urine bag can hold about 500 milliliters of liquid, which is about the average contents of the human bladder. And then once the bag is filled, it can be easily drained using the drainage valve on the urine bag. At the end of the day, when it's time to clean, all of the components, both the cup and the urine bag, can be cleaned using either boiling water or hydrogen peroxide, and then the shorts can be cleaned using any traditional fabric washing methods. Finally, we want our device to be accessible and affordable, so we've priced it around $46 per biker short, but this cost will ultimately go down once manufacturing in bulk.
So far, in the past month, we have performed initial verification and validation testing on this first prototype. Overall, this testing has been successful in determining that our design specifications are met and that this could fulfill the need of women with vesicovaginal fistulas. But through usability testing, there have been some design improvements that we've identified. So next steps are working to improve these design elements, specifically the connection between the urine cup and the tubing. We want to make sure that's secure so that we don't have an interruption in urine flow. And then finally, we want to evaluate the manufacturing methods to make sure they're as seamless as possible. Ultimately, our hope is that in the future, this device could be fully manufactured in the regions where the need is prevalent.
How long, so just like any other usable disposables, they have a shelf life. So for example, like people with CPAP devices, their hoses are replaced every so often, like every 6 months. How long would you anticipate each of your devices to last? So i.e., how many times would someone need to buy a new set?
We're hoping that our device can be reused for up to 24 months at a time, and this would include all components of it. So we've selected materials that can withstand all the sterilization and washing processes, and so they approximately every 2 years they would need a new device.
You got to have enough tubing that when they move around, run, stretch, sit down, pull the shorts down to go to the bathroom, get back up, that there's enough tubing, but then the tubing doesn't get in the way or irritate them otherwise. And then it's just looking around, we're all different sizes, so that would affect not just the size of the cup, but how much tubing you would need and how big the bladder, synthetic bladder would need to be. So how will you even, you said you've done some preliminary testing. Was that one person wearing this stuff around or different people, or how have you figured out that you're sort of on the right track as far as a system that will work? Because I love the idea.
Yes, so actually all three of us have worn the shorts, and they can be manufactured to fit anywhere's customization. So the shorts, we use a sewing pattern that can accommodate different sizes, but you can also purchase these biker shorts in a variety of sizes to accommodate each woman. And then additionally, our cup model and our mold can be customized for any woman's vulva. And then the tubing can also be, the length of that tubing can be changed in order to accommodate the dimensions and the wearer's activities. So all of that can be modified.
And for the tubing, initially we cut it too short so that when we did do the activity testing, it would become disconnected from the cup. So then in our next models, we lengthened the tube, but then we had problems with like the sides of like the tubing tract that was on. So we have to find like a more pliable material that will better connect to the cup and allow for movement during activity, because we tried it while biking and walking like normal activities during those the days of these women. So we still have improvements to make there.
St. Louis University, who will present on their teamwork on anemia assessment in resource-poor regions.
All right, hello everyone. We're excited to be presenting our project on anemia assessment in resource-poor regions. My name is Moog Chermany, studying medical sciences, and I'm accompanied by my teammate Jake Little, studying mechanical engineering, and we're part of an interdisciplinary team from St. Louis University. The central motivation for our research project is the global health challenge that is anemia. Anemia affects about over 2 billion people worldwide. That's about a quarter of the world's population, and as this map shows, that spread is not equitable. Areas in orange and red on this map have much higher rates of anemia. We see sub-Saharan Africa, Central America, parts of South Asia. It's a fact that anemia is more common in areas that are low income. Since anemia is characterized by an insufficiency of red blood cells, it can be detected by measuring either hemoglobin or hematocrit, the percentage of our blood comprised of red blood cells. In severe cases of untreated, anemia can lead to maternal mortality, birth defects, organ failure, and a host of other negative health outcomes. Luckily, in many cases, anemia can be successfully treated, but before we even reach that stage, must first be diagnosed accurately in the patient. And there currently exist several diagnostic methods to do so by measuring hemoglobin or hematocrit, as I mentioned. However, many of these methods are cost prohibitive. They're resource intensive. They're simply not accessible to the regions mentioned in the previous slide. Let's look at a few examples. On the top row of images, you'll see the automated hematology analyzer and the standard centrifuge, two gold standards for measuring either hemoglobin or hematocrit. However, these tests are not easily portable. They require electricity, and costs can extend past thousands of dollars in US currency. On the bottom left, you'll see the handheld reflectance meter. Now that's simpler, cheaper, more portable, but it still requires batteries and disposable components. That spells into two challenges for low resource settings. And on the bottom right, you'll see the World Health Organization's hemoglobin color scale. Now that's about as simple and inexpensive as you can get, but it still requires, it still has some accuracy issues. It's also fairly subjective because it's based on the test taker's interpretation of the color, and it's only semi-quantitative. It gives you hemoglobin results in ranges of 2 grams per deciliter instead of a single fixed value. So for the nearly 1 billion people globally who rely on healthcare facilities with either no or unreliable electricity access, along with deficiencies in other resources, there's an urgent need for an inexpensive yet still quantitative hematocrit or hemoglobin test to detect anemia. To reiterate, our target population are those living without key resources, just electricity mentioned earlier, but also climate control, refrigeration, financial funding, highly trained personnel, and other resources. This diagram breaks down the statistic mentioned earlier about the people living with unreliable or no electricity in their healthcare facilities. It breaks it down by global region, and the map on the right plots those regions. They're colored in orange and yellow. The map on the left you've already seen. The purpose of comparing these two maps is to show that the same regions that have high rates of anemia, the problem, also are deficient resources needed to access and afford the current test for anemia. So you have a problem and you have inadequate solution. You combine the two, and you see drastic negative impacts in population health in these regions. That's where we come in. Our lab at St. Louis University has devised a test called the falling drop method, which, as you can see in this image, requires no batteries, no electricity, no complex instruments, and it's simple and doesn't require highly advanced training from the personnel running this test. This test works by pipetting and dispensing 44 microliters of venous blood in a glass column containing copper sulfate solution. The basic principle is that the heavier the blood is, meaning the higher density, the higher the hematocrit is. Multiple studies in the current literature have shown that there's a relationship between density and hematocrit because the major component of the mass of blood is red blood cells. Plasma solutes and other components have a very minor, almost negligible role in mass compared to the red blood cells. So the heavier the blood, the higher the hematocrit, the faster it'll descend, and the lighter the blood, the longer it'll take to fall down this glass column. So by tracking descent time of the blood manually with a stopwatch, we can then inversely correlate that with the hematocrit of the blood sample. And we've done this in lab using tests, and then we found that there is an R-squared value of 0.96 when we do our linear regression analysis, showing that hematocrit can be reliably and reproducibly determined from the descent time of the venous blood in this test. So to summarize, some successes of this project are that it requires no complex instruments, batteries, electricity. The copper sulfate has a shelf life of over 7 months, meaning it's not going to degrade in storage conditions, especially in even higher temperatures, higher ambient temperatures, such as in sub-Saharan Africa or places closer to the equator. And it does give us a fully quantitative hematocrit determination. However, one limitation is that the test requires 6 drops of venous blood to be dispensed before it can average out to a reliable, consistent hematocrit value. That does pose a problem in terms of efficiency in these clinics. Also, manual timing by a test operator might also pose limitations in terms of efficiency. So ease of operation and efficiency is kind of one big area where we're hoping to make strides with this test.
To address some of these problems that Mo brought up, we aim to produce an automized system that can time the descent of blood in these columns. It'll use an infrared photo gate that can detect and time multiple blood drops at once. The benefit of doing this is it eliminates the need for consecutive timing. So samples can be dropped one by one, and then the total computation can be done using the microcontroller, and the outcome can be read by the tester. We can see here what the overall system will look like, where it could be manufactured on site using products that are there, such as wood and different hanging systems, and then electronics can be composed elsewhere and shipped to site and incorporated easily. Next slide. So overall, because of the simplicity of the photo gate, we can use simple components, which are just IR, LEDs, and receivers, which can detect these blood drops. And overall, it produces a reliable system that can be easily implemented and replaced if needed, off-site or on-site, depending on the location. So one of the needs of this system is that it has some sort of electricity, which could be a generator or low-level power, which can be on-site at some clinics. This fills the need for some of these testing systems because it doesn't operate on batteries like the others and uses less disposables, and it remains at low cost with these simple components. Here is a prototype that we've done using low-cost components and easily manufactured capabilities.
Explain a little bit more about the manual timing of the blood drops.
Yeah. So if you go back to this image, so we have a glass column. There's at the top a little piece of plastic that's just a modified pipette tip to help stabilize the pipette when you're dispensing blood so your hand's not shaking. So the blood droplet is dispensed. We let it kind of settle. If you've ever seen blood hit a solution, it kind of disperses and then collects a little bit. So we let that variation for a couple centimeters. And then when it's kind of collected as a consistent blood droplet, that's when we start the time. So we have a marking on the test tube where to start the time so it's consistent among different droplets. We start the time with a stopwatch, and then we have a similar marking at the bottom, so it's a fixed distance for all blood droplets. We stop the time, we have a descent time measurement in seconds, and then we can inversely correlate that to the hematocrit of the blood sample. Does that answer the question?
2 questions. 1, how did you get this idea to use the copper sulfate? And then 2, can you use the same column like so many times for different patients? And like how long would you estimate you could use one column?
Yeah, so to answer the first part of the question, well, copper sulfate's a pretty cheap and common solution in many of these tests. The reason is that it's an ionic compound, blood is charged, or the proteins in blood are charged, so it helps coagulate the proteins in blood and keep it as a droplet so it doesn't disperse, and it also retains the integrity of the solution so that we're not having remnants of the blood left in the copper sulfate as much as it might be in other solutions. So that's the worth of the copper sulfate. In terms of your second question, which I'm blanking on. Yes, so we don't really have any idea for limitations in that. It's a glass column. Copper sulfate doesn't stain the glass. The blood doesn't stain the glass if it's cleaned out. Even in our lab, just simply filling it with dilute water, distilled water, and emptying it tends to remove all visible signs of any blood stains and any signs of copper sulfate. So we do think it can be indefinitely unless it chips or breaks or has done so many trials that you do still see stains. But as long as it's washed out, it should be usable for many tests.
Lungs Up from Stanford University.
Hi everyone. We are Lungs Up. I am Leslie.
And I'm Amanda.
And I want you to introduce you to Naya. Naya is a single mom from New Delhi in a shanty town in India. She actually goes into a polluted community which is pretty crowded. These past 3 days, Abby, her son, a 3-year-old kid, has been presenting symptoms of coughing, low hunger, and high fever. symptoms that are pretty quietly common in any cold or respiratory infection or respiratory condition. Naya is a single mom. She's working every day 8 to 6 p.m. She doesn't have enough time to know what to do with Abby. And especially, she doesn't know if it's the right time to go to the hospital, or does she need to wait for Abby to continue developing these symptoms. However, the issue is that these symptoms, as broadly and general that they seem, they are also symptoms of a very fatal infection, pneumonia. Pneumonia is the infection, the fluid buildup in the air sacs of the lung, consisted of several types of microbiomes, viruses, bacteria, and any other fungi. This increase in fluid buildup can actually consequently cause exhaustion into kids and low oxygenation level, which triggers deadly consequences. Indeed, pneumonia is the cause of over 700,000 deaths in the world for children under 5 years old, which disproportionately affects the developing world, specifically South Asia and West and Central Africa, which the average number exceeds from the average. So we in LungSub, we really want to develop something that lets parents be able to recognize pneumonia development specifically at home, so that they know when fluid buildup is getting consequently damaging for their communities, so that in a larger scale, they can optimize their medical resources into their hospitals.
This early detection framework is what we framed our device Mucoscope around. Mucoscope is a low-cost, easy-to-use, and developing to be accurate device used at home to detect early detection of pneumonia. And so what is our device? Our device is a stethoscope-like attachment that directly attaches straight to the aux port of your phone, which then is able to analyze different recordings through our algorithm, and is then able to give a likelihood of whether pneumonia was present or not. And so with our design, we went through many reiterations of our stethoscope-like attachment. We have our CAD design right here for our stethoscope head, and through testing different stethoscope heads with our 3D design, a cheap stethoscope and an expensive stethoscope head, they all performed very similar, and so we decided to go with the cheap one. We also did many reiterations of different tubing and microphones that were used in our stethoscope design, and so once we were able to finalize the different parts, it all came to around $25. And so as you can see here, we have like our recording in the back of the child's back, and we are able to have an output of different waveforms. But in terms of accessibility, we know that parents are not able to see these waveforms and know what they mean. Like, what does it mean? How can you analyze these results? And so then we come to our UI design of our app. And so our app is simple, easy to use, and it's efficient. It has a step-by-step process of how to take a recording in 15 seconds, and at the end, it gives you a result of whether pneumonia was detected to be present or not. We were very mindful that many of our users will not be speaking English. They are non-English-speaking speakers, and so we have many different icons that are available to guide the people through using the app. We had a trial run of 15 Peruvians, all of whom don't speak English, come from low-income backgrounds, and don't have any medical background. And all 15 users were able to navigate the app within 5 minutes without any outside help. And additionally to that, we're able to add some more features that we got from feedback from those users, one of them containing a GPS type of screen that allows them to see resources in their area, such as hospitals and different types of areas, and also past recordings and different resources. As for our algorithm that we are using, it is a binary classifier, and essentially we use over 1,000 online lung sounds and 4 of our own lung sounds to train it, and from that we were able to get 97% accuracy. One of our future steps and goals for the future is to get in-person positive pneumonia rates, because that's kind of hard to obtain in person to get the positive pneumonia rates, but that's something that we're looking to do in the future.
So where is pneumonia compared to standard of care? As you can see right here in the efficacy affordability chart, the resources in hospitals do work. Imaging can tell you how much is the concentration and where the fluid buildup is actually located through MRI and CT scan. However, getting into hospital resources takes a long time, and moms do not have that time. On the other side, you have pulse oximetry available. But these aren't really accessible because parents do not really know what each number means or where to locate into the finger. We are in a time in which COVID pneumonia is happening, and COVID pneumonia is developing severe pneumonia, which can ultimately get into hospitalization, especially in kids. So vaccination campaigns and antibiotic resistance is actually another threat for the current treatment for pneumonia. So mucoscope is actually there. It's effective enough and it's affordable enough. They let parents know when to take their kids into the hospitals at the right time and to acquire these resources. Because our project is actually part of something bigger. We really believe that everyone in the world should access advanced health technology, that everyone deserves to get early detection of diseases, and specifically that the open source knowledge should be for all, starting with Naya and Abby and continuing with the rest of the world. Thank you so much.
How did you decide how many measurements for the mucoscope, and then where did you measure on the patient?
Measurements, you mean like the location in the body? Oh yes, we did throughout testing on frontal area and background area. Anatomically speaking, the lungs are located here, so it's easier to recognize the crackling from the lung sounds on the back, and that's what this is using. We are using spectrograms and sound frequency and amplitude measurements that are already in our classifier algorithm.
Listening to the lung, are there any other disease or symptoms that you can also categorize?
That's a great question, and actually our future direction is for mucoscope to be able to recognize any presence of fluid, so any respiratory distress. However, our classifier has been training pneumonia because it's more widely known, but specifically it's just measuring anything that is on the lungs, so that when it reaches a certain threshold, parents know that it's time to go to the hospital, no matter what it is inside.
Can you explain how the device would be practically deployed? Is this something that you would anticipate all new parents would buy and just have handy just in case? Or is it something where if their kid was sick and they were worried, they'd run out to a pharmacy and then buy it? I don't quite understand how that would work.
That's a great question. We believe that mucoscope would be a public health measurement, so all neighborhood councils, because coming from actually Peru and knowing how this method works, municipalities do have primary care kits, so that we are willing for municipalities to access them as a $25 kit for families. So anyone within a neighborhood can access that, and ultimately we can also get it personalized to be in a pharmacy. But we are conscious that parents won't be buying this in a one-on-one basis, but rather would be a communal share-up.
Team Bambasuade from Universidad de los Andes.
Hi, my name is Andres, and Andrea, that's with you, my partner and friend. We're both students from biomedical engineering at Colombia in Universidad de los Andes. Let's Andrea take care of you from now on.
So let me introduce you to Chocó, Colombia. It is one of the most magical, beautiful places in my country. It is the westernmost region in Colombia, which is located in the north of South America. However, it is also the most impoverished region in Colombia. The poverty hits almost twice as high as in the rest of the country. So let's keep Chocó in mind while we talk some stats. There's a total of 500 newborns born in Colombia every year. And of these, 30% are born with a congenital heart disease. Of these 30%, 14% die within the first month, and 30% die within the first year. But this is not just a problem in Colombia. 1.35 million babies in the world are born with GLHT. This means it's the most common birth defect. And 40,000 experience this situation in the US only. Also, 1 in 4 babies with a GLHT is in critical condition and needs immediate care. So meet Lucas. He's a newborn baby, 2 weeks old, and the first child of a single mother. He was born with a GLHT and his family is not aware. Lucas' likelihood of mortality, just because of being born in Colombia, in Chocó, is twice as high as the average of the country. And Lucas and countless other kids don't have access to proper medical care because there's only one secondary care hospital in Chocó that doesn't have an ICU and doesn't have a surgery unit. That is why Lucas' family is worried, because neonatal care in these situations is not precisely performed, not immediately available. Then who actually treats Lucas? Midwives. In communities like this, midwives are the carers. So meet Carmen. She has delivered over 1,000 kids, and this is a real life story. She started when she was only 16 years old because there was no one in her community to help a pregnant woman, and these women ran outside and just asked anyone to help, and that is when she came to the aid. So what's the journey of Lucas' mothers to give a diagnosis to his baby? She first has to travel multiple hours to keep the hospital. That is a secondary care hospital, and it's already very far, just to see if there's anything wrong. Then she has to see the pediatrician and be referred to a cardiologist that is not in the department. So she has to leave her job and make a great investment that she might not have the money for, and travel at least 400 miles and over 20 hours just to get to another hospital that might be able to treat him, but is not sure.
And that's why we're presenting you an easy-to-use, low-cost wearable with a smartphone app that will allow us to detect early signs of cardiac disorders on all those newborns and refer to them to doctors when access to quality medical service is needed. So let me introduce you to Tiny Heart Wearable, a piece of clothing that will be able to acquire ECG signal and measure oxygen saturation data, and via Bluetooth broadcasted to an app where alert abnormalities can be raised. And this same data can be processed and sent to a medical contact who can determine if treatment is needed. So our successes until now are that we already developed an early wire wearable with the app design prototype. And also we designed the functional circuit, and we did a signal acquisition test on us. Also, we have the first algorithms to process the ECG signal. And the best part is that we only need $12 to manufacture this product and improve Lucas' life, as well as many of other children. Nowadays, several initiatives from the Pan American Health Organization and the Cardio Infantil Hospital, that is an outstanding hospital in Latin America for because Regalo Una Vida, it's a program that creates brigades to bring cardiac health to children that cannot access to it. And our solution would widen their scope to screen all the children that possible have cardiac diseases. The principal features of our product is that the precision. Well, we have these experts that have helped us and aid us validate all our process, from tech and health innovation, and from physicians, pediatricians, and cardiologists, and electric and electronic engineering for the functional circuit. Our features are precision, that it's easy to use, and there is no training that it's needed to use this app. This is also highly adaptable to other ages, and it's low cost and viable. Our limitations: proper access to reliable devices. On low income settings, it's known that not everyone has access to a smartphone, but in Chocó, it's been proved that at least 50% of the population has access to a smartphone. Connectivity is also another challenge that we have ahead, and cultural barriers to technological tools will be something that we have to work in. Our future work is finish this design and manufacture the product with all the features we want to do. Continue developing the analysis algorithms along with physicians to improve the diagnosis capacity of our product and adapt this to other ages. So maybe elderly people can use it, or maybe another children that are not newborns and need this, the need of a screen their alert, so they can use it. We also want to make it reusable for this low income setting, because in the world, more communities like Chocó and thousands of babies like Lucas exist. And that's why we want to work together with us to ensure that babies born in low-income settings have an equal chance of a healthy life.
Have you thought about the impact of motion artifact on the signals you're acquiring?
Yeah, we're working right now on that. Our last iteration for the design of the piece of clothing included a sash to try to improve the precision of the electrodes and make them more tightly positioned to the body.
Your sensors, are they off the shelf? Are you guys sewing them into the onesie? If you can further expand on that.
Yeah, so for our manufacturing, we want to use foam electrodes because they are hypoallergenic and they're comfortable for the baby. We right now are working on how to make them very tight to the body so the signal acquisition is precise. But also we are considering using a method of clicking them off so the piece of clothing can be washed and reused for longer.
Andrea, you can show them our prototype that we have after the presentation.
Yeah, so this is one of our prototypes, and if you see the blue blankie, will work as a sash. We're trying to see how tight it has to be, but we're trying to make it to make more important the part that is hypoallergenic and comfortable for the baby's skin.
How did you decide when they should go see a doctor?
So our app is merely a screening method. So if there's any abnormalities, it will alert the mothers and the midwives to take the baby to a doctor.
And that's why we want to raise the alert so the mother or the midwife knows that something is wrong. Also, we want to send this data to the doctor that maybe we can assign at keep the hospital, or if some organization want to work with us, so we can send them all this data and the doctor can see whether what has happened with the baby and what kind of abnormal activity.
Team Stable from University of Pennsylvania.
Yeah, because by assigning the baby to a doctor before, with these organizations we talked about before, we are making the road to the access to medical care quicker.
Welcome Team Stable from University of Pennsylvania.
Hi everybody, good afternoon. My name is Gloria, this is Moses and Dylan, and today we will be introducing to you a new innovation in emergency medicine, and we call it Stable. So there's a problem with IV access in ambulances. 28% of IV insertions in all scenarios fail on the first try, and this number is probably even higher in ambulance and emergency settings. So this means that with 600,000 daily ambulance calls, and over half of them requiring IV access, there are more than 100,000 failed IV sticks daily. So this number goes to show is that emergency transport can be uncomfortable for patients, and it can also be difficult for paramedics. So paramedics generally choose to insert IVs on site rather than en route, which delays transport to care. And this problem is more pronounced in rural and low resource settings when transport times are already longer and advanced healthcare centers may be further. And what this all comes down to is when dealing with the most critical patients, any sorts of delays in care can result in detrimental outcomes. So why is an IV so hard to insert in the back of an ambulance? Well, there are several reasons. First of all, a paramedic has to deal with varying vein visibility within patients, and they also only have 2 hands to work and deliver care to the patient. They're also working in a space-restricted environment, and with potholes and bumps in the road, the stability that is required to perform delicate medical procedures is unavailable.
Enter Stable. Our device seeks to streamline vein visualization and IV insertion so that paramedics and other care providers can insert an IV on the go with ease, limiting transport times and also improving patient outcomes. So there's nothing like Stable that exists on the market currently, although there is a precedent for vein visualization, and that comes in the way of a tool called AccuVein. However, AccuVein suffers from numerous limitations that make it ill-suited for usage in an ambulance. The first is that it requires manual operation. And we've already discussed that paramedic hands are already a limited resource. Secondly, the device and the underlying technology is cost prohibitive in many scenarios. And finally, and perhaps most crucially, it offers nothing in the way of stabilization. Our device, Stable, consists of 3 key components that drive its functionality to overcome these limitations. The first is Stable's armband, which consists of a cushioned Velcro strap, which allows for quick and easy general securement, as well as an integrated BOA lacing system that can be twisted and tuned to ensure that there's no slippage or drifting along the patient arm during transport. And the device can be removed as quickly as it can be put on thanks to the quick release technology of BOA. Our second component is our vein imaging pipeline, which is primarily positioned above the intended IV insertion site on the patient's forearm. Since deoxyhemoglobin in our blood absorbs significantly more IR light than surrounding tissue, we can actually, by doing imaging within a certain wavelength range, get a clear trace of the patient vasculature, the superficial vasculature, regardless of skin tone. So for these purposes, we're using an ESP32, which is a lightweight and inexpensive microcontroller, an infrared sensitive camera, and then a variety of physical filters to capture a live feed of the vasculature. This live feed can be viewed in Stable's mobile app, likely on an in-ambulance phone mount for convenience for the paramedic, and we can get frames like these. So first we have a raw snapshot, and it's not super bright, but this is what the camera can glean just with the physical filter. And then this is what a paramedic would actually see on the app after it's put through our contrast enhancement algorithm. We're excited to note that we actually just recently validated a lightweight in-app machine learning model that segments vasculature on open source retinal image data, because that's what was available. However, we believe that if we can adapt this model to in-house forearm data, incorporate that into our contrast enhancement pipeline, and then use that in the app, that we'll get even better visibility in the future.
The third and final subcomponent of Stable is the needle insertion guide. And it consists of a 3D printed guide that allows for one axis of motion. It also allows for insertion depths of up to 5 millimeters to allow for access to subcutaneous veins without the risk of puncturing arteries. And the band allows for slight adjustment in case there are veins that aren't perfectly parallel to the arm. We've taken into account reusability and good manufacturing practices. Those are critical to US regulatory approval when it comes to reusable medical devices. In terms of implementation, we're focused on using open source software and low-cost hardware to ensure that the device could be made locally if needed. Our cost of goods is below $25. And through our partnerships with local fire departments, we're able to do situational testing in moving vehicles. Now, of course, there are a couple challenges we still have to work out. Right now, we're relying on Wi-Fi hotspots, which, although readily available in ambulances in the US, are not available in all global health settings. So we're working on alternate means of allowing for wireless connection between the device and a mobile device. Regardless of your situation and your resources, we want you to be able to use Stable. And therefore, it's a modular device. You can use the vein visibility and the needle insertion abilities together or separately. Originally, we intended Stable to be used as emergency medicine settings such as ambulances. However, early on in the design process, we realized that it has much broader implications. So we iterated our design process to account for global health parameters. Developing countries can struggle with limited personnel, lack of training for their personnel, and lack of access to more expensive vein visibility technologies. Therefore, through Stable's inexpensive, ergonomic, and modular design, we're able to use it in situations such as training, where you could train personnel to better insert IVs in arms or better detect veins without Stable. We could use it in the clinic, where only vein visualization may be needed, or outside the clinic, where needle stabilization with or without vein visualization could be required. Stable's ability to transform emergency medicine in the US will work in conjunction with its ability to be used in global health settings around the world.
That's a great 2D visualization. Is there a way of actually calculating depth of the vessel? So we use vein finders when we have toddlers in the OR. They have pudgy arms, so you can't really see anything. And so we use those vein finders, and it's really helpful, but it produces just exactly that, a 2D picture. So unless you have that experience to know the depth of the vessel itself, the only thing about this, the 1 point entry is that you're at a confined depth, whereas then sometimes you have to shift it up or down to be able to actually get to the vessel.
Yeah, so that was something that we considered, was adding this angle of motion to account for just needing to change the angle of depth. We ended up deciding to go with a fixed angle. Once again, for these training purposes, we wanted to kind of minimize any extraneous movements that could alter or affect where exactly a paramedic is intending it to go, if that makes sense. And also, we were hoping that with the modulation of having that depth up to 5 millimeters, you can also decide to go not all the way 5 millimeters in and kind of modulate that depth, as well as how far down you go into the skin with the needle. And ideally, that is something that you do have to get a little bit of training with, understanding what the depth of the vein is. But overall, our device is able to help it kind of isolate that kind of intuition that you need to have to understand what the depth of the vein is.
Also, were you asking about the visualization component or the mechanical in terms of depth for understanding? Sure. So that, the general IR tech, like you really are only getting a top-down view. So unless we were to somehow incorporate also IR light from the side and then have a potentially other camera source, which is a little bit beyond the kind of small ergonomic design of the device, you'd have to do that. But we were talking about there's a hard stop on the device to make sure you're not going further than 5 millimeters.
AccuView vein finder, when you use it, you get like a real world image and it's projected onto the patient so you can actually see where the vein is. But on your guys' model, it's projected onto a screen, right? And then you have to use that as a reference to go back to the arm. Is there any reference point that you can use when you can't see?
We want to put a reticle onto the screen. We just didn't have time to calibrate it precisely enough to where it'd be useful. The idea would be to calibrate a point on the screen where we know the needle will go. So you could look at the screen as you're putting on the device, see the reticle, you know it's going to go in that place, look away from the device, clip in your needle, slide it in, knowing it's going to hit the spot that you intended on the screen.
Yeah, actually calibration is really the only last step. But the camera, which is, again, retractable in at the top, and the carriage itself move in tandem with each other. It's just been us changing the design of the track. But once we finalize that, it really is just a matter of calibrating the virtual reticle and then what's available on the device itself.